Dr. Ahmed, we'll start in 2 minutes, huh?
Yeah.
We'll start at 7 sharp.
والمسجلين 400 يقول لغاية الآن.
طيب, that's very good.
دكتور خالد كيف الحال؟
أهلا وسهلا أستاذ.
حياك الله.
حياك الله دكتور أحمد.
الله يكرمك. حياك الله. نحمد الله.
الحال حول يا دكتور أحمد.
الحمد لله.
احنا عندنا 50 و52 حرارة امبارح واليوم.
حرائق إن شاء الله ما في. حرائق إن شاء الله.
حرائق قدرنا
طيب.
نتغلب عليها
إن شاء الله.
امبارح إن شاء الله.
ربنا يحفظ الجميع إن شاء الله.
ربي يحفظ الجميع إن شاء الله. كيف الصحة؟
نحمد الله ونشكره. نحمد الله.
مهند, we're gonna start, huh? مهند إبراهيم. Okay, دكتور أحمد تفضل.
بسم الله الرحمن الرحيم. السلام عليكم. Good evening everybody. Good evening friends and colleagues. On behalf of the Jordanian Society of Obstetricians and Gynecologists and the Royal College Committee in Jordan, Palestine and Syria, I would like to welcome you all to this very important webinar dealing with maternal death in the Arabic world. We have invited very good eminent speakers from Egypt, Lebanon, Saudi Arabia, Tunisia and Jordan. This important topic is going to deal with causes and how to prevent maternal death in the Arab world. As the postpartum hemorrhage is one of the main causes of the maternal death in the Arab world, we thought we should invite an eminent speaker and experienced man in this field, Professor Tim Draycott, who's going to start this webinar. Professor Tim Draycott is Professor of OBGYN and University of West England. He is the Vice President of RCOG for Clinical Equality and Strategy. He's the author of 1,300 peer-reviewed publications, and he is the author of the obstetric textbook in Cambridge University. He is now supervising the PROMPT program, which is dealing with the practical obstetric and multi-professional training. And Professor Draycott gets many prizes. The most important one is from the Queen Anniversary Prize of Excellence in 2014. Please, Tim, Professor Tim, the floor is yours, dealing with BPH. Thank you very much for sharing with us this webinar. Professor Tim, the floor is yours.
Dr. Ahmed, thank you very much. Thank you very much for inviting me to speak from cold, not very sunny UK. And I couldn't agree more that postpartum hemorrhage is one of the key issues in all of our countries. So let me, here we go. So look, delighted to be able to share with you. I think what I think has been quite an exciting year for postpartum hemorrhage prevention, with some really important big trials that are really helping us understand this. So let me just say, can I say I'm missing working with you all? I'm missing everyone in Jordan, many friends in Jordan, many friends in Egypt, Saudi, Tunisia, hopefully one day, and the Lebanon. So, and as I said to Dr. Mazin just before we started, no one leaves Jordan to eat in the UK. And so let me say thank you very much, everyone.
Thank you.
And we're all working through a kind of shared global experience. And I just wanted to give you a slide. And I know Dr. Hassan is laughing at me that the UK has a hot weather warning at 27 degrees, but that is the cold northern country we live in. So let me just say that I think, and I'm afraid I'm going to miss the last couple of speakers, but I think all of us are going to say, look, PPH remains a really important contributor to maternal mortality. And the one thing I think we can all agree on is that prevention is better than management. Okay, sometimes we are going to have to manage these women, but if we can prevent it, then I think that's a key issue. As I said right at the beginning, there are significant new data on PPH prevention, and I'm going to try and synthesize these new trials into what I think they mean for practice at the coalface for us who are looking after women every day in labour. And I'm going to try and divide it into high and low risk, and I think there is definitely a slight difference in what we do at caesarean versus vaginal birth. So, okay, we all know, and I'm sure the next four speakers are going to say, look, you know, maternal mortality is one of the biggest problems across the world, and PPH is the biggest problem now. Interesting, in the UK, maternal mortality from PPH has gone down, but now it's a significant cause of maternal morbidity post-birth. And I think what the WHO have said many times is most can be prevented by uterotonics, medical and surgical techniques, but let's talk about prevention predominantly. It's about 27% of maternal deaths globally, about 250,000 women die every year, and I'm sure the Middle East is part of that. In the UK, it has decreased, but as I said before, it's the leading cause of maternal morbidity now in the UK, and PPH rates are rising across the world. Although in some settings they're going down, the mortality is going down, the rate of PPH is going up for all sorts of different reasons, which maybe we'll come on to. So let me just give you some highlights from the recent UK reports. And one of the key things is we must think about blood volume when we're managing women with PPH. We need to measure it accurately, and I think in the UK there's now almost ubiquitously people just weigh the sheets at the end of the bed, and that gives you a measurement of the PPH. And we also have to think the same volume affects small women more than big women. The second thing, and this is definitely an issue across the Middle East, is maternal anemia increases the risk of PPH and also the effect. Now, look at how many women are now on anticoagulation. We need a proper plan for those women. But the bottom line is, still the bottom line, is active management of the third stage of labour is the foundation of PPH prevention. So let me talk about that. I'm going to talk about the uterotonics and really focus on those, the three big recent new trials, and also the recent data on tranexamic acid for prevention, not just for management. So let me just start with vaginal birth. This is Loic Sintelius's study, the TRAP1 study, where they gave tranexamic acid as a placebo after oxytocin at vaginal birth. Doesn't make any difference. So tranexamic acid routinely at vaginal birth does not seem to be useful. Now, I'm going to come back to the cesarean section because it might be useful at cesarean section. But at vaginal birth, it doesn't seem to be useful routinely. So let's have a think about then the third stage of labour. And from when did I start? obstetrics, 1992, I think, 1991. Almost everything has changed about the third stage of the active management of the third stage of labor. So we definitely need to delay cord clamping for more than 60 seconds at all births, cesarean and vaginal births. And there are significant advantages to the mother and the baby. And if you look at this study from Sweden, a very interesting study showing that if you delay cord clamping more than 60 seconds at vaginal birth or cesarean section, it improves outcomes, fine motor and social domain outcomes at 4 years of age, particularly if you're a boy. Now, we don't quite know why that is. Is that an improvement in sort of anemia? But it is definitely an improvement. So we should delay cord clamping at least 60 seconds at all gestations for all births. Controlled cord traction doesn't seem to make a big difference. A really big study by the WHO, and what they identified was actually pulling on the cord doesn't seem to make a big difference, doesn't really affect the risk of severe hemorrhage. Therefore, what the WHO said is we have to focus on the uterotonics. So let's quickly whip through some of the uterotonics, particularly the new data. Okay, in lots of parts of the world, misoprostol was thought to be just a great hope for PPH. And okay, there may be a place for the use of misoprostol for the management of PPH, but there is not a place for the use of misoprostol for the prevention of PPH. It is not as effective as either oxytocin or ergometrin to prevent PPH. Now, these are the three big trials, including one from my own unit, my own region, in fact. So 3 big studies have come. The Champion study, which many of you may have recruited to. There were certainly a number of women recruited from Saudi, I think, and Egypt. The IMOC study, which was our study, and the Labour study, a very interesting study from Dublin with Deirdre Murphy's group. There's also a network meta-analysis, some international recommendations, and I'm going to kind of talk about those as we go. So the Champion study, really big study, published in the New England Journal, nearly 30,000 women randomized to heat-stable carbetocin or syntocinon, both IM. Okay, they're exactly the same. They are exactly the same. Carbetocin and syntocinon seem to be as effective IM as each other. The IMOC study, this is a study from my unit, as I said, where we randomized 6,000 women. Now, 70% of units in the UK use synthometrin, ergometrin and syntocinon together routinely for PPH prevention. So we randomized to IM syntocinon, IM synthometrin, or IM carbetocin, again, the heat-stable version. And we powered the study for both non-inferiority one way and superiority another way. And okay, synthometrin is slightly more effective in that it reduces additional uterotonics compared to syntocinon and carbetocin, but carbetocin and syntocinon are, just like the Champion study, almost identical. However, synthometrin has significantly more side effects, and anyone who's used ergometrin knows about the nausea, the vomiting, the headache, the abdominal pain, but also, and this is where side effects are really, really important. Can you see in the IMOC study, we identified that these side effects reduced the mother's ability to bond with her baby. These are really, really important things. And we also identified in the IMOC study that PPH risk was increased after the induction of labor. And look how many extra women we're inducing these days. And much increased after assisted vaginal birth for both PPH and transfusion. However, one of the things I'm going to try and say today is there's no useful clinically valid prediction tools to determine high and low risk births. The Labour trial, again, a really important trial published in BMJ. It randomized women to IV or IM syntocinon after routine vaginal birth. And you can see that the severe PPH rate, more than 1,000 mils, was almost halved with IV syntocinon. And the blood transfusion rate was halved with IV syntocinon compared to IM. So IV syntocinon seems to be better than IM, but I'm going to talk about the risks of IV syntocinon as well. And notice in this study, the benefits of IV syntocinon were only really seen in women who've been induced and primiparous women. So let me give you what I think. What does this mean for us at vaginal birth? Okay, there's no clear best option. Synthometrin is effective but has significant side effects. Plus, you have the same issues of storage as syntocinon. If you have a look at the syntocinon, it seems to be the least effective IM option, but there are potential risks with IV use. Plus, you've got the issues of storage and quality. And carbetocin is effective with low side effects and has the benefits of being thermostable, but of course it's more expensive than syntocinon. So we have to work out, is it worth the extra money or is it not worth the extra money? And the network meta-analysis, I think, will help us understand this for vaginal birth. So this is the network meta-analysis by Janos Galos and Ari Kumarasami's unit in Birmingham. And they identified that, look, there were 3 drugs more effective than oxytocin. So synthometrin, as I've shown you from our study, carbetocin was more effective, interestingly, when they did all the studies, not just the 3 big ones. And also misoprostol and syntocinon together was more effective. And if you have a look at these results, okay, what do they mean? So if you gave just syntocinon, oxytocin to women IM, about 10.5% of women would have a PPH more than 500. But if you gave synthometrin or carbetocin or misoprostol plus syntocinon, then you can see it's about 7.5% compared to 10.5%. So that's the magnitude of difference. But they also identified, like we did in the IMOX study, that the side effects of synthometrin and misoprostol were much, much higher than carbetocin. And I think any of us who've used misoprostol know the shivering and the pyrexias and everything else, and also the ergometrin side effects we know about. So the conclusion in the network meta-analysis, using all the data available, not just the 3 big studies recently, was that carbetocin had the most favorable side effect profile amongst the top 3 options. Now, what does the WHO say? The WHO says, look, oxytocin, either IM or IV, is recommended for PPH. And what it says is, where carbetocin is cost comparable, then we maybe should use carbetocin for vaginal birth. Now, let me talk about cesarean section. I think in cesarean section it's much clearer there is definitely a best option. So if you have a look, this is the TRAP2 study that's just been published in the New England Journal by Loic, the chap from Bordeaux who published the TRAP1 study. And they showed that if you give tranexamic acid routinely at cesarean section, you definitely reduce the blood loss less than 1,000 mils. So you can see 30% with placebo and 26% with tranexamic acid. No additional side effects, no additional everything. Now, what I think this means is, where you think you may have some bleeding at cesarean section, be it a complicated section, be it other issues, tranexamic acid, so we use tranexamic acid in the UK now quite commonly at cesarean section, put the spinal in, give 1 gram tranexamic acid, then start the incision. And I think that is clear now that tranexamic acid does seem to be effective at cesarean section. Now, but here's the problem of syntocinon IV. Okay, in the old days, you're all, I'm sure, far too young to remember when we used to use 10 units of syntocinon IV, wham, at cesarean section. Used to give it to absolutely everyone. And now it's 5 units in the UK. And I think in Germany, it's now 3 units IV. Because syntocinon IV has an association with coronary artery spasm, ST depression, and hypotension. And so therefore, I'm cautious about recommending IV syntocinon at vaginal birth because we would use 10 units there. And I think we've just got to be cautious with its use at cesarean section too. Now, let me just summarize, I think, some of the important studies in this area. So this is the ESSIT study where they tested whether or not an infusion of 40 units post cesarean section was useful. Okay, it's definitely not useful. There's no difference in major obstetric hemorrhage between a bolus or a bolus and an infusion. So for us, we have now said in the UK, there's no point using a 40-unit infusion routinely at cesarean section, which seems to be, we went through a period of a year or two where everyone seemed to be doing that, but we now know that's not a useful thing to do. If you look, again, this is from my own unit, we randomized people from carbetocin or syntocinon at cesarean section, and you can see that carbetocin reduces the requirement for additional uterotonics. You get the maximum effect with just a single dose. And I think you all know that carbetocin lasts 40 minutes rather than 4 minutes, which is syntocinon. And that's probably the reason why this longer lasting effect of carbetocin seems to be very, very beneficial at cesarean section. If you look at the Cochrane Systematic Review from 2012, you can see it's absolutely very clear and said, look, carbetocin is more effective than oxytocin for preventing PPH in women undergoing cesarean delivery. And there are more data recently. This is Asma Khalil's group at St. George's, where they did a kind of Bayesian meta-analysis looking at the just carbetocin and syntocinon studies at cesarean section. And you can see from this forest plot that carbetocin is associated with reduced additional uterotonics at all cesareans. Okay, it's not just our work. You can see our work is quoted there, Atalakos at the top. So it definitely is a useful thing to do at cesarean section. And can you see there's a reduced blood transfusion rate at high-risk cesarean sections too? Interestingly, the anaesthetists are very interested in this area too. They are very concerned about the use of intravenous syntocinon. Carbetocin does not seem to have the same direct coronary effects as syntocinon. And what the anaesthetists have said is, look, if you use carbetocin, you don't have to use an infusion. And they are now recommending in this really big international consensus that maybe carbetocin should be the first-line drug for cesarean section. And if you have a look, we actually, I don't know about the Middle East, but certainly carbetocin is about £10, £9 UK sterling here. And syntocinon is about £1. And so therefore we had to work out, okay, is it worth spending the extra money? Well, we then did an economic impact analysis where we looked at our randomized trial and we did this sort of Monte Carlo simulation all the way down to try and work out what's the benefit of carbetocin to the whole journey of the woman at cesarean section. And we calculated, we made a cost saving of £18.31 per cesarean section. So if carbetocin costs less than £18 in a UK setting, it is definitely cost effective. And for us, almost routinely now, everybody is moving to carbetocin routinely at all cesarean sections. So what are the practice implications of all these data for us every day here in the UK and globally? Okay, tranexamic acid may be useful for prevention at cesarean section, and I think we should have a low threshold for using it. Okay, the routine use of a syntocinon infusion is not effective, and we could do without that. There are significant benefits of carbetocin at cesarean section, particularly reduced additional uterotonics. Yeah, you don't have to use an infusion because the 40-minute half-life of the carbetocin does away with the requirement for an infusion, reduced blood transfusion, and it saves money in our service because of the cost. So let me just give you some practical things from this is our unit. This is the snow, just to show you how cold it is sometimes here. We're about 6,800 births a year, about 250 midwives, 20 residents, 9 consultants, and about a 26% section rate, although that's definitely creeping up, I'll say that. We've done, a couple of, 2 really big randomized trials now, including the LOXI study in 2010 and the IMOX study just most recently. But after the LOXI study in 2010, we introduced carbetocin routinely for everybody in our service. And we do about 1,750 sections a year. And with a regional referral service for placenta accreta or, morbidly adherent placenta, whatever it's called these days. And what was interesting is when we had a look at our service, carbetocin not only reduced additional uterotonics in our service, but when we looked at time in recovery, it saved 25 minutes per woman time in recovery. So that's better for the nurses and midwives, it's better for the doctors, and it's definitely better for women who'd rather be on the ward with their baby than in recovery after a cesarean section. Now, a lot of people ask me, okay, that's fine, and carbetocin sounds like a good idea, and let's start using it. But what effect does it have on the management of PPH if you're the 7.5% of women who do have a PPH afterwards? So remember, carbetocin half-life is about 40 minutes. I think we should be very early on tranexamic acid. Now, I will just say one of the things we have to say, I'm sure is no news to all this experienced audience, but one of the things we've had to emphasize to the juniors is that tranexamic acid only works when you stop the bleeding. It stabilizes the clot. So you've got to get on with the suturing as well as deal with the tranexamic acid. I think the second line uterotonics use just standard options after carbetocin, so ergometrin, prostaglandins, and there's no requirement. We don't use a 40-unit infusion after carbetocin at vaginal birth or cesarean section. And they don't seem to have the same risks as giving loads and loads of uterotonics that sometimes people used to in the old days. So room temperature stable. So even in the cold UK, 5% of the time, the fridge in our trial for IMOX was warmer than 4 degrees. So fridges are not as reliable as we kind of think. And one of the issues of room temperature stable or refrigerating syntocinon is not like Coca-Cola, where it doesn't matter what temperature you have until you put it in the fridge before you drink it. Syntocinon needs to be less than 4 degrees from the moment it leaves the factory all the way through to the time you give it to the woman. Now, I think room temperature stable has advantages in that you don't have to worry about that. I think for us, we found it much more usable. I think there are generics now that are actually not routinely used in the UK. But one of the big advantages also for carbetocin is because you don't need infusions and everything else, you don't have multiple IV lines. Just use it in a standard way. So let me just summarize and think what I think the future might be for PPH prevention. I think we should start to develop prediction tools that are useful for us at the coalface. I think that would help us personalize care, give the right care to the right woman. I think we do need to think about tailored prevention. I will say that at high-risk vaginal birth, should we give IV syntocinon or IV carbetocin and tranexamic acid? I think that's something to be worked out. Cesarean section, I think, is absolutely clear. Carbetocin, vaginal birth, less clear. But there do seem to be benefits of thermostable preparations. So just to conclude, please, 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 all of us should delay cord clamping at least 60 seconds at all births, vaginal birth and cesarean section, at all gestations. Control cord traction doesn't make a massive difference. And thinking about the new data on uterotonics, the network meta-analysis says that oxytocin is the least effective at both vaginal birth and cesarean section. However, it is currently recommended. Let's acknowledge that. Carbetocin is more effective at cesarean section. It seems to be cost effective at cesarean section and recommended for vaginal births. And there may be some advantages to being thermostable. So one of the things I'll say is, and I'll be very happy to share the links for these afterwards, if anyone wants to access some free training resources that we put together for the UK, including PPH, including presentations, videos, algorithms about the management of obstetric emergencies, then by all means, you can download them from here. And if you email me afterwards, I will definitely be able to signpost you to the free downloads of all the resources that you can access. And I just want to say thank you very much to the Jordanian Society for inviting me. And thank you, Dr. Ahmed, for that lovely introduction. And this is the new RCOG. Now, I'm sure many of you are members and fellows. Many of you have been to the old RCOG when it was in Regent's Park, but this is the new RCOG by London Bridge. And I really look forward to welcoming you all to your new college, our new college, when we can all start traveling again. So thank you very much once again, and shukran for letting me speak.
Thank you. Dr. Ahmed, are you with us? Can you unmute, Dr. Ahmed, please? Can you unmute? We cannot hear you.
So right now?
Yes, go ahead.
Thank you, Professor Tim, for this very comprehensive lecture about PPH, and which contains very new ideas dealing with the prevention of postpartum hemorrhage. I can see there is questions now. Questions, answers.
Yeah, just click on Q.
There is two questions from Dr. Fakhr Shatnawi. For those who have severe thrombocytopenia, platelets less than 5,000, planning for CS, what is the best protocol for management to prevent PPH, and how we will continue post-surgery?
Yes, so that's an interesting question, and yeah, so the key issue there is in our service we'd have to do a GA for platelets less than 50,000. Above 50,000, we will still do a spinal in our service. I think these severe thrombocytopenias, it's so dependent on the cause of the thrombocytopenia and how acute the thrombocytopenia is that we'd have to seek advice from the hematologist. However, assuming that this was stable and let's say idiopathic thrombocytopenia, then I think we would probably cover the cesarean section with some platelets during the cesarean section, definitely give tranexamic acid, be very careful with hemostasis at the cesarean section, and I probably would put a drain in where I don't use a drain routinely at all at cesarean section. Now, postnatally, I think once the bleeding has stopped, this woman is very likely to be okay as long as the platelets stay around about 50, even above 20, should most likely be fine. But for the surgery itself, you may wish to seek advice from the hematologist, but have a think about platelet cover and careful hemostasis like we all do anyway.
Thank you. The second question, from Dr. Ibtisam Hassan, how to manage patient with history of BPH due to retained placenta in previous pregnancy, i.e. how to prevent the recurrence at next delivery? Again,
The simple answer is I don't know. And I don't think anyone knows. I don't think it's just me. We did look at whether or not there was a difference between syntocinon, sintimetron, and carbetocin for the rates of retained placenta, but there's no difference at all. So it doesn't seem as if an individual uterotonic may help. I think if this is a woman in my service, I would encourage her to have a normal vaginal birth. I would give her active management of the third stage of labor, and I would say she's got a low risk of recurrence, but there is a risk of recurrence. I mean, at least partly, these women seem to have risk of recurrence because they may have an underlying deficiency in the endometrium at some place, around. So I think I would probably put an IV line in and be ready to manage her in the third stage, but I don't think I would change her care per se.
Thank you very much. I'm sure we have good ideas, and we hope we can implement these ideas in our practice in Jordan. Sir, regarding prompt training, is it online the same quality like the in-person? We used to have it in person in UK.
Yeah, Dr. Ahmed, I'd like to say I was better in person.
Yeah.
But I think that we wrote the course that's available for units where people can't travel. It was difficult to get access to training. And so we would definitely much prefer to do it in person. We've done it very successfully in Egypt, extremely successfully in the Philippines and Zimbabwe.
So we hope we have one in Jordan as well.
Yeah, perfect. So, but I think while you're waiting, then feel free to download it, and we'd love to share it.
Yes.
But can I ask a question for?
Okay.
Thank you, Professor Draycott. Our problem here, I believe everywhere in the world, is when to decide to go for surgical procedures when drugs fail to stop postpartum hemorrhage.
Yeah.
And because that's a very important question here, because sometimes if you decide to do hysterectomy or internal ligation or back rib ballooning or whatever, like PLH, at what stage you said, enough, drugs are not going to work, I need to do surgical procedure?
That's a great question, Dr. Mazan. And you know that in the UK, one of the criticisms has been people have started that too late. So you're absolutely right. That's a really excellent question. What I would say is, I think it's worth trying drugs, clearly, if you've opened the abdomen and you can address the underlying condition. So take the placenta out, do a B-Lynch, whatever. I don't use balloons very much, I'll say that. I think the balloons work quite well for lower segment bleeding. I know that Arul Kumaran is very keen on balloons, and we discuss it a lot. But I think if it's affecting their blood pressure, affecting their pulse, and you have not got control of the bleeding, I think you should move to surgical options.
Okay, thank you very much.
Thank you very much.
Thank you. Okay, no more questions. Thank you very much, Professor Tim.
Thank you very much.
Thank you very much.
Thank you very much indeed. Hope to see you in Jordan sometime.
Okay, it'll be my privilege.
Thank you. Our next speaker is Professor Hassan bin Saleh Jamal from Saudi Arabia. And Professor Hassan is the professor of OBGYN at King Abdulaziz University Medical School in Saudi Arabia. He is the ex-dean of the same medical school, and he is the ex-chairman of the Saudi Arabia OBGYN Society, and he was the past chairman of the Federation of the Arab Societies of OBGYN. Dr. Hassan has attended 150 conferences and meetings. He has got the first prize for medical research in Saudi Arabia. He got 150 prizes and medical appreciation for best research in 1995 and 2009. He's the author of many books dealing with women's health in the Arab world. Dr. Hassan Jamal, please, the floor is yours.
Bismillah wa salatu wa salam ala Rasulillah. Good evening, ladies and gentlemen. And it's my great pleasure and honor to be with you, thanking the Jordanian Society of Obstetrician Gynecologists at the Royal College to invite me to talk about the trends in the maternal mortality in the Kingdom of Saudi Arabia. Actually, it is no doubt mortality has been falling, but in contrast, the maternal mortality in the United States have been increasing in recent decade, and I will mention that later on. And there's substantial variation among countries and within the countries, as we can see that in the major city is different from the rural area when we have a high number of the maternal death. The absence of high quality population based data is one of the challenge for all of us to measure the actual maternal mortality. And the maternal death are relatively rare events, even in countries where the maternal mortality rates are high. So large sample sizes are needed to estimate both maternal mortality risk and contributor to the maternity death. Why maternal mortality in the United States increasing? Was surprising because most of the viewers said, is that true? The answer, yes. The Center for Disease Control and Prevention reports that maternal mortality in the state have been increasing in recent decades from 10 deaths per 100,000 live births in 1990 to a high of 18 deaths later on in 2014. And in 2015, it was 26.4 deaths per 100,000 live births. That means, reviewing these cases, that 60% preventable. And that's I'm going to mention later on how it comes all these preventable and there is no much action have been done all over the places, not in the United States. Improved identification of pregnancy-related death and change in the coding and classification may account for most of these rises. Now, the other contributing factor why the maternal mortality is increasing the maternal age, increasing body mass index, and we know that the country number one and obesity all over the places is USA. Comorbidities, change in the proportion of the rural women, increase in the immigration rate, increase in cesarean section rate, and that's all of us who are concerned now all over the places. Cesarean section rate is increasing, and increase in the chronic medical condition. This is why the state having this figures. Now, the global incidence and trends in the maternal mortality ratio. Between 1990 and 2015 have been combined by WHO, UNICEF, UNFPA, and other agencies are now available online. And actually, which we are happy about, that 44% felt between 1990 and 2015, with a significant variation between countries according to the income levels. For example, in high-income countries, 13 deaths per 100,000 live birth. In the middle-income countries, 180, and in low-income, 479, and that's very sad, actually. And now we see figures increasing by the conflict in the region, like in Yemen. In 2013, as far as I can remember, it was 5 deaths daily. Today is 13 deaths daily. So something which is really the difference between maternal mortality ratio and maternal mortality rates. The rate is the number of maternal deaths in a given period per 100,000 women of reproductive age between 15 and 49 during the same time period. Why the maternal mortality ratio is the number of the maternal death during a given time period per 100,000 live birth. So here the denominator is different, and this is why it is different when you mention that one and the other one according to what you are talking about. Now, when actually the maternal death takes place, is it during pregnancy or during delivery or the perperium? Approximately 1/4 maternal death globally occurred antepartum. Another 1/4 occurred in the intrapartum and immediately postpartum. 1/3 were subacute and delayed postpartum deaths. The remaining were late deaths. In the United States, between 2011 and 2015, 31 occurred during pregnancy, 17 occurred on the day of delivery, 19 occurred on the day 1 to 6 postpartum, 21% occurred within day 4 to 42 of delivery, and 12% occurred 43 days, 1 year after delivery. What that means? More than 50% occurred during the postpartum period. So we need to have a lot of attention in the postpartum period. Antepartum period improved by looking after the antenatal care, and the standard of care have been going up to some extent in certain region, and this is why we minimize the maternal death during the antepartum and intrapartum. But postpartum, we need another tremendous effort to minimize it. Global cause of maternal death, generally speaking, complex and multifactorial, as you know, and contributing factor are the patient herself or her family, and the health provider or the facility delayed. And actually, the major delay factor we can see all of us after all these years of experience, that delayed in the decision to take care, because sometimes your decision is too late. And this is why we say that 60% preventable. Delay in the arrival to appropriate facilities. Please, any high-risk patient, you have to be, or she has to be, in a proper place for delivery. Delay in receiving adequate care on time. If I have time, I let you a lot of stories about these three delayed, which causing the maternal mortality. Worldwide specific cause of maternal death, WHO in 2014 say that obstetric hemorrhage 27, and mentioned already by Prof. Tim, hypertensive disorder 14, pregnancy-related sepsis 11, abortion 8, embolism 3%, other direct cause 10%, indirect 28%. Epidemiology of maternal mortality in Kingdom of Saudi Arabia. Facility of data on maternal death in Kingdom of Saudi Arabia and triennial study, which every year done on maternal mortality, was the first of its kind, with objective of forming if the national database, we can work on it and to help us to reduce that part. And the cultural, actually the cultures and the socio-demographic pattern of Kingdom of Saudi Arabia have got contradictory epidemiological risk factor for maternal death, as I can show you now. On one hand, economical affluence has brought a rapid expansion and improvement in nutritional standard, free public sector health services, public sanitation, and impressive network of communication. But on the other hand, social customer of early marriage, unregulated high fertility, high proportion of elderly grand multiplex patients, and lower literacy rate among female are generally considered as epidemiological high risk factor for maternal mortality in the kingdom. The major cause of maternal mortality death in Kingdom of Saudi Arabia by Muhammad Najmuddin, 2018, that the most common cause of maternal mortality in Kingdom of Saudi Arabia is obstetric hemorrhage. Together with hemorrhage due to uterine rupture and abortion, it contributes to 43% of a direct maternal death. Advanced maternal age and high parity were specific risk factor for death due to hemorrhage. Female over 35 years old and over contributed to 38% of death due to hemorrhage, and equal number was contributed to the grand multiplex patient. Now, when we look to the contributing factor cause of maternal death in the Kingdom of Saudi Arabia, increased maternal age and parity, low socioeconomic status, obstetric hemorrhage, pulmonary embolism, ruptured uterus, hypertensive disorder of the pregnancy. And what the strategic plan to reduce maternal mortality in the kingdom? Number one, general improvement in the socioeconomic status, increase in the female literacy rate, and a lot of work going on that part, shifting from home delivery to hospital delivery, and now we start to be, I mean, in the past it was a high percentage, nowadays less than 26%, and skilled care during pregnancy, labor, and perperium, and a lot of training now in most of the hospital, whether in the Ministry of Health or other sectors, trying their best to improve the education and training for the medical staff and the other health providers. Contraceptive practice and reduction in the fertility rate, and all of us, we can see that one, but not like before, we have a large family. Now, vision of 2030 in Kingdom of Saudi Arabia, that the government has announced its vision of 2030, and that vision organized into a number of themes. And one of these is to improve the quality of health services delivered to the community from the capacity of a developing country to the level of the modern economy. And this will improve significantly the maternal mortality. The maternal mortality ratio model estimate 2017 Kingdom of Saudi Arabia, when you look at it from 2006 to 2017, we start from below, is 21, 2007, and so on, until in the last, between 2013, 2017, is 17, the value of maternal mortality in the Kingdom of Saudi Arabia. And I think that's good achievement. I remember maybe more than 10, 20 years, it was 55. Now we got 17 per 100,000 live birth. International comparison maternal mortality between 1989 to 1992. When you look to the developed countries like United States, United Kingdom, Sweden, etc., it was 8, and then Sweden 5, Japan 11. In the Gulf states, Bahrain 19, Kuwait 10, Qatar 14, Saudi Arabia 18. And the developing countries, very sad figures: Pakistan 279, Sudan 520, Nigeria 800, Yemen 1040. So it is very clear about these statistics, what the situation on these countries. 2017 changed the figures, and you can see that United States 19, Saudi Arabia 17, Canada 10, France 8, Germany 7, and the United Kingdom is 7. And waiting for other colleagues also to mention there in Egypt and Lebanon and Tunisia, etc. So to conclude my talk, that the maternal mortality in Kingdom of Saudi Arabia has significantly reduced due to increased female literacy rate, organized antenatal pregnancy and delivery care by skilled health providers, and the commitment of the devoted government to improve the health of the nation. Hopefully, maternal mortality in the Kingdom of Saudi Arabia will very soon matching the developed country with advanced health facility. Thank you very much.
Shukran, Dr. Professor Hassan, for this nice talk and the view of maternal mortality in Saudi Arabia. My question, do you have in Saudi Arabia a nationwide committee to deal with these cases, or it's hospital-based study?
No, we have national and the Ministry of Health, and they are reviewing all the hospitals in different sectors. As I mentioned, that the Ministry of Health, the private sectors, the governmental and military also. They have a national committee.
Thank you very much.
And in each hospital they have, they have it, but there is a national committee.
Dr. Ahmed, can I come in, please?
Yeah, please.
Thank you, Dr. Hassan. Excellent presentation. And I think your figures are reassuring, and of 17 per 100,000 is very good figure, really. And I'm sure you're working to reduce them further in the future. My question is home deliveries. What percentage of deliveries in Saudi Arabia are home deliveries? Because in Jordan, we have between 95 to 98% of our deliveries are hospital deliveries. So what's the percentage in Saudi Arabia?
Well, the figure in 1995, it was 26, but now it's reducing to maybe 10%. But definitely there is nobody encourage the home delivery. But there is, in some rural area, they might still having the normal delivery at home.
And you believe that if you reduce the number of home deliveries, you might improve the figures
Oh,
on
definitely.
mortality?
Definitely. I can tell you a lot of story that they deliver at home and then they have severe bleeding until they got the ambulance to transfer the patient to nearest hospital, they die.
Yeah, yeah.
Oh, definitely. We are against home delivery.
But I think the challenges that you're having is very similar to the challenges that we're having in Jordan. We'll go through them later on tonight. Thank you, Dr. Ahmed.
Inshallah.
Thank you. It's my pleasure to introduce my colleague, Dr. Maher Maitat, to introduce the next speaker. Dr. Maher, please.
Is Dr. Faisal with us? I can't see. Is he with us, Dr. Faisal?
No, Doctor, no.
So you're going to play the recording?
Yes.
Okay. So we will, I think Dr. Faisal agreed to be with us, but I'm not sure because of the internet connections in Lebanon and Beirut and maybe the electricity problem. So he kindly recorded his presentations, and we're going to listen to his presentation on maternal mortality in Lebanon. Dr. Faisal Al-Qaq is well known to all of us. He's a vice president of FIGO. He's a clinical and associate of obstetrics and gynecology and sexual health and director of the Women Integrated Sexual Health Program at the Department of Obs and Gynae at the AUB Medical Center in Lebanon. He's a senior lecturer and faculty of health services at the AUB. He's coordinator of the National Committee on Safe Motherhood with the Ministry of Public Health. He is chair of the National Technical Committee on Corona and Pregnancy, and he's the editor of Maternal Mortality Audit in Lebanon. So he's going to talk to us about maternal mortality in Lebanon. Can we start the presentation, please?
Ibrahim.
Ibrahim, are you okay?
By recording because of unexpected electricity cuts and internet cuts, so just in case. I want to welcome you all, and I want to thank the organizing committee, my friend Dr. Anad, Dr. Abdul Wahid, Dr. Mazen, Dr. Hamad, and the others for inviting me to this event. And talking about our experience in the maternal mortality in Lebanon, the context. How we get there to improve maternal mortality and the current status. I have nothing to disclose. As we speak, currently we have close to 200,000 women that will die every year because of causes related to pregnancy and childbirth. Still, postpartum hemorrhage remains the main cause, 27% by big cancer and hypertensive disorders at 14%, and sepsis due to 11%. Still, this is reflecting serious health system issue and the clinical care and quality issue in the low middle income countries, as you all know. According to the recent report from the WHO, every day 810 women die from gender causes like two airplanes crashing into a mountain every day. Despite this dramatic fact, the maternal mortality ratio dropped by 38% worldwide over the past 18 years. However, it remains high in terms of the rate of maternal death in the low middle income countries, more so among young adolescents facing high risk complication and death. Still care before, during, and after birth have been shown to save lives in women and newborns. A lot of countries have done many remarkable efforts towards the MDG 5. As you can see, MDG 5 is the Millennium Development Goal that was meant to observe and watch over countries trying to achieve and grow maternal mortality by 75% over 15 years, while 37 countries experienced accelerated decline in the maternal mortality since 2003. 40 countries have achieved 5.5% of the MDG 5 pace, and 7 on track to meet MDG 5, and 8 is the number of countries with increased maternal mortality. Unfortunately, many great countries like the United States are among the 8 who have been witnessing a drop or an increase in maternal mortality. Of course, unfortunately, abortion complications, hypertension, and hemorrhage represent almost 50% of all the maternal death. Here in Lebanon, we are one of the winners, and we are one of the 18 countries that achieved MDG 5 by 2013, meaning dropping maternal mortality by around 75%. We are one of the leading in the Arab region and one of the leading in the countries who have achieved the MDG 5 according to the WHO. Within the global and regional context, as you see, in Western Asia, Lebanon ranks way in the top. The average of this region of the maternal mortality is 71 MMR, with a range between 48 and 110. We still lose around 3,500 women per year, with a lifetime risk of maternal death is 1 in 430, definitely more in the developing region all in all. This is for the MENA region, North Africa and the Middle East, as a feed into Africa Lancet 13, and you can see Lebanon has been dropping its numbers from 124 to almost 24 over the 13 years. This is another new article, Lancet 2014, affirming Lebanon's rank with annualized rate of change ranging between 6.7 and 8.6 improvement in the maternal mortality. Dropping maternal death, as you will see in my presentation, from 65 maternal death in 1990 to 12 in 2013, and this is the distribution of the countries who achieved: Estonia, Lebanon, Lithuania, Latvia, and others across the distribution of the other countries on the track to meet the MDG 5, and you can see the red square for North Africa and Middle East, where Lebanon is doing way much better as compared to the other red squares on this graph. So why Lebanon achieved the MDG 5 and also 3 and 4, that has to do with neonatal and prenatal mortality, because we moved into restructuring our health system from that was really broken during the Civil War and following the Paris Agreement in 1990, where we have the civil rest. We started with the help of UNFPA and many other organizations and WHO in building structures that will help improve our health indicators. And that's why we used to have these indicators. This is the indicator that I have collected based on random studies, including the systematic method that was used by the top child in 1995, which is a study of the LMD, showed our maternal mortality to be the ratio to be around 104. Other studies showed the 300, others 126. So all these were random numbers. The last one is the PACTAM, which is the Pan-Arab study for families, is around the maternal mortality around 86 MMR. Well, we don't stand still. Okay, we started by doing the proper collection with the systematic method, the projection method that use analytic factors to project the maternal mortality, and that was for most of us as practitioners and academicians not correct and not precise. The Ramos study that was conducted around 2008, which is the reproductive age mortality study, one of the serious methodology studies collecting death in reproductive age women. We had 84,823 live births in Lebanon with a numerator of 13 confirmed pregnancy-related death. This was compared with other subsequent sets to estimate the ratio of 15.3 in 100,000 live births, indicated the mean of the interval between 15.3 and 30.6, coming up with the MMR of 23 in 100,000. This improvement was accompanied by the formation and official National Committee on Safe Motherhood. I was part of this, and now I'm coordinating with this committee. We did more research study. We went to the primary health care centers for training, and also to the reproductive health program, which is active in the ministry. And we developed the most important notification system of hospital-based and even home-based deliveries. This will be reported to the NCSM, which is the National Committee on Safe Motherhood. We developed an expert group from the Lebanese Society of OBGYN. This group will look at every case reported from every hospital in Lebanon to the focal points of the ministry. The one of the experts will go there and they will meet with the hospital director, with the maternity, and with the attending doctor in charge, and analyze and look at the case and assess and estimate and analyze the potential causes of death and what went wrong and what are the lessons we can learn from this case. For this reason, we used a template that we developed over 6 months of work. It's called the Maternal Death Review. It contains all the necessary information regarding facility details of the disease, admission details, clinical care, delivery, postpartum neonatal information, risk factors for assessment, interventions that were done, cause of death, and also what are the avoidable factors, all the factors contributing to the maternal mortality and the official cause of death. In addition, there is an emergency case and care assessment, and an autopsy in case they're subjected to an accident, an incident, or in case you have violence against the pregnant woman. All of these are documented and reported electronically to the DOD, to the vital observatory data at the Ministry of Public Health, analyzed across all the indicators, and every 3 to 6 months the committee will need to look at the cases, discuss them, study them, and get the lessons learned. This process was documented in a report story of success that I Director General for الأعمال published in 2016. Published in the International Journal of Gynecology Obstetrics, a paper on the maternal mortality trends in Lebanon, again confirming a maternal mortality ratio of around 14.9 for Lebanon, which is way above the expectation of the MDG, again discussing the national notification system of the maternal and neonatal death. Also, we did more interventions, early detection and referral. We sensitized the providers on the 3Ds of WHO and implemented an early detection system and referral for specific tertiary centers and hospitals for the high-risk cases. There was continuous medical training and capacity building for the providers all over Lebanon, in addition to awareness and trust. One of the examples of early intervention is the abnormal presentation. We had a cohort of maternal death around 2011, 2012, 2013 because of abnormal presentation, and this was brought to the attention of the committee, and the committee, following the national meeting we had in 2013, have adopted 3 hospitals, the American University Open Health Center, the Hariri University Hospital, and the Victoria St. Joseph University Hospital. These are the 3 referral centers, and we put a standard guideline on how to assess a case of previous cesareans to make sure there is no abnormal presentation, and if there is abnormal presentation, they will contact the committee, and the committee will refer the case in question to one of the three hospitals where we have a team of gynecologists, surgeons, radiologists, anesthesiologists, blood bank ready to make sure and take care of these cases. And so far, there was no, after 2013, reported cases of death. Out of 150 cases of abnormal presentation, no reported maternal death because of that. And that was a big success. As I said, the capacity also included healthcare providers that are providing care and clinical care for the refugees. We have every year close to 50,000 deliveries of the Syrian refugees, which is another burden on the health system. However, this also was taken care of, and there was no increase in the maternal death ratio, and there was no increase in the number of maternal death, even in the presence of 50,000 deliveries of Syrian refugees per year. This is the distribution of maternal death in Lebanon. The red is the north, brown is the south, blue is the east, green is the west, and these areas, as you can see, they have similar range of cases. Recently, 2016, 2018, around 15 cases across the periphery, and 3 cases in Beirut, including, of course, Lebanese and non-Lebanese. As the distribution by age, you can see in the last 18 years, in the 2017, 2018, we have more death of adolescent pregnant women, and that's because of the prevalence of adolescent and teenage pregnancy among Syrian women. However, the other cases of death would be somewhere between 25 and 35 and the difference was not significant, except for the rise of the teenage pregnancy or teenage maternal death. These are the 25 causes of death. You can see maternal causes, bleeding, sepsis, hypertensive disorders, and you can see also non-OB causes, which at one point was on the rise, again because of late screening and late booking of antenatal visits by the Syrian refugees. And you can see over 2019, 2020, we had almost over 2016, 2020, almost there is only one case of death due to abnormal presentation, thanks to the prevention we did earlier. Again, in Lebanon, the number, the bulk of maternal death factors was preeclampsia, embolism, postpartum hemorrhage, and non-OB. As I said, non-OB is rising, which is very similar to the trend in some countries like the UK and others, because of the non-communicable disease increase in pregnancy, and in our case because of finance, of transportation, of course, pregnant women are not seeking care earlier, which prevents us as providers from detecting the chronic condition. This is the trends of maternal mortality counting more than 10%. You can see comes first the preeclampsia, embolism, postpartum hemorrhage, post-MDD, and non-OB again appearing in more than 10%. If you look at the trends in maternal mortality counting 1 to 5%, then factors like sepsis, pneumonia, H1N1, and COVID in the 2020-2021 will appear. In 2020, we had 4 cases of COVID. In 2021, we had 17 cases of COVID, and that were serious numbers. However, now with the push we have done and the vaccination, we have a really increasing number of pregnant women who are vaccinated, and that's protected. And since April, we have not seen any maternal death due to COVID-19. We are more or less comparable to the developed world in terms of the causes of death, if you look at this, in terms of hypertensive disorders and postpartum hemorrhage at the same time. If you look at this slide for Lebanon, so we have postpartum hemorrhage, hypertensive disorders, and embolism, in addition to non-OB causes. And if you look at the developed countries, again, You can see hypertensive disorders, sepsis, and non-OB. So we're somewhere between developing and developed countries pattern. This is just to show you in the paper published in an international journal that we have also increasing, not significant increase in the indirect causes of death, which also should pay attention to by improving early detection and early antenatal care. The recommendation is to strengthen the reporting, and we are doing that. We are issuing a maternal health report every year or every 2 years. We are also working on other mechanisms to identify high-risk cases and to have a guidance and effective treatment in this, and also continuing the referral that we have mentioned. We have conducted around 18 training sessions on management of pregnant women with COVID-19, and we continue to do that. We work to centralize and referral of high-risk and near-miss cases. Now we have a project looking at the near-miss cases and the identification of 20 of painful and pregnant women. The results will be out by November, and this project is supported by WHO. Again, we look to conduct qualitative and quantitative and operational research to improve. This is some of the colleagues in the expert group of the Lebanese Society that are working to investigate each and every case. I want to thank you very much. I want to thank the Ministry of Public Health and Government, the Lebanese Society of Children, and the UNFPA for the support of this maternal mortality reporting, and I wish you all the best. I will try to be with you in the evening. You're really okay to answer any questions.
Thank you, Dr. Faisal, for this comprehensive talk about maternal mortality in Lebanon. I do apologize for the poor quality of the sound because it was recorded and we have no control over the sound system. So I just wonder if Dr. Faisal is with us or he's not. Because, I mean, we have a variation in the maternal mortality. What was reported around 86 per 100,000, but the latest report in 2016 was 14.9, so quite a variation. And I would like, but anyway, if he's not with us, then we'll go on to the next speaker. It's my privilege to introduce Professor Khalid Niji. He is a professor of obstetrics and gynecology, past president of Obs and Gynae Society in Tunisia. He's the head of Department of Referral Maternity of Tunis. He's executive member of the National Tunisian Committee of Maternal Mortality since 2011. He's actively involved with FIGO projects, and he's the vice president of the Arab Federation of Obs and Gynae Societies. So Professor Khalid, welcome to this webinar, and he's going to talk to us about maternal mortality in Tunis. Please, Professor Niji.
Thank you very much. Many thanks, Dr. Maher, for your kind presentation. So good evening, everyone, and welcome to my presentation. First, I would like to thank the Jordan Society of Gynecology and Obstetrics to invite me for this virtual meeting about the tricky topic, which is maternal mortality in Arabic world. I am speaking to you in my quality of head of department of gynecology obstetrics, the biggest referral maternity level 3 in Tunisia, which is managing about 15,000 labor per year.
Dr. Khalid,
can you share your slides, please?
Share your slide.
I shared it.
No, doctor.
No, you have to do it again.
I did it. It's okay?
Yes, okay.
So I said that I'm speaking in my quality of head of department of referral level 3 maternity in Tunis, which managing about 13,000 births per year. I'm member of the Maternal Mortality National Committee since 10 years, more than 10 years, and I am two consultant to WHO in Tunis office. In the beginning,
can we have a full slide, please? A full screen? Can we have the slides covering full? Yeah, thank you very much. Yes,
okay.
Excellent. This is excellent. Thank you.
Yes, yes. For the beginning, I would like to offer this bouquet of flowers to our all Arab women in Arab world because it is 13th August and the Women's Day. As it has been already announced, maternal mortality is still very high in developing countries because a large proportion of maternal deaths are due to delayed or substandard emergency obstetric care. There is an urgent need to develop and validate interventions to address this delay in our law research settings. Most are community-based interventions that provide funds for facilitating women transport for childbirth, information, education, and communication for large public and almost the pregnant woman, and improving referral system and medical practices at different levels of healthcare. As you can see on this slide, 99% of 303,000 maternal deaths occurred in developing countries. Sub-Saharan Africa alone accounted for 66% of deaths, followed by South Asia. And in Maghreb region, maternal mortality rate varies from 62 to 700 per 100,000 live births. So, as you know, last decade and still today, our quiet Tunisia became noisy and effervescent because we are living new political and social events, but we hope some better days in the near future. This slide shows some official statistics about Tunisia for the most curious among you. But now Tunisia is still and always a beautiful country and small country, it's important small country, which has enabling legislation for women and an effective contraceptive policy since 60. This table shows that maternal mortality rate in Tunisia is similar than those in Russia, for example, or Latin America. In addition to these favorable demographic factors, we were lucky to benefit from effective family planning policy, as proved our contraceptive rate 62% and fecundity rate at 2.2. As you all know, Tunisia is the only Arab country where abortion is legalized since 1964, and the direct consequence was a decreasing of maternal mortality ratio. Therefore, during the last 3 decades, the downward was clear with a drop from 131 in 1990 to 62 in 2015. More than that, as my quality of leader member of the Maternal Mortality Committee in Tunis, the recent preliminary statistics during the last 5 years place maternal mortality rate in Tunisia between 40 and 50 per 100,000 labor. The main cause is that the Ministry of Health was encouraging since 7 years GYN specialists to work 24-hour shifts in rural and disadvantaged areas with remuneration about $220 per shift. Which women die in Tunisia? The poorest, the less educated, and those who live far from healthcare facilities. In this context, the three model delays should explain the majority of non-medical causes of maternal mortality, like you see in this table. For the socioeconomic factors, the delays concern decisions within the family to seek care. This situation is so rare in Tunisia. Concerning the access to hospital, the delay concerns transport, and finally, the factor influencing use and yield healthcare quality. The delays concern within the health facilities, and this problem is unfortunately yet frequent problem in Tunisia, especially in the rural maternity, level 2 and 1. Let's move to medical causes of maternal mortality. As you can see on this graph, like in most incoming developing countries, PPH remains the main cause of maternal mortality, followed by preeclampsia and thromboembolic complications. The severe infection and sepsis arrive in fourth position, contrary to the situation in some neighbors' countries. Thanks to abortion legalization since the 60s, we report very few cases of maternal mortality in the first or second trimester due to unsafe abortion. That's why ectopic pregnancy remains the first cause with 2.2% of cases. Moreover, we remark since 10 years many maternal deaths due to emergent pathology such as the placenta carita, which is a direct consequence to the incredible increasing of cesarean section rate in Tunisia and in some public hospitals and the majority of private clinics, the rate cesarean section can reach more than 74%. So it is very important to have a credible and collective data tool to have a clear idea about the specificity of each country. It's very, very important, and my first message. Since 2002, our maternal mortality committee is analyzing maternal deaths, causes, and identifying malfunctions. The main of them, these malfunctions, are unequal distribution of wealth. There is an alarming poverty rate in Center-West district versus the Center-East, for example. There are many difficulties of recruiting qualified staff in rural areas, and we live since 10 years doctor exodus to the West, which is our real problem now. So need for funds and mostly a sound government are required. And among our maternal mortality committee conclusions, despite of this relatively acceptable maternal death rate, nearly 75% of cases could be avoided if women had access with no delays to vital and basic health care. So the notion of avoidability is a way of reasoning that should be analyzed in context. I agree with my brother Faisal Al-Qaq because there are few cases of maternal death. So the main benefit of the near-miss concept is using near-miss cases rather than maternal death. In that is that obstetric complications are far more common than maternal death, allowing for a statistically more robust quantitative analysis. We initiated in my department since 2 years a near-miss group, working group, in our reference level department, and the first conclusions until now are very useful. Unfortunately, recommendations from maternal mortality in our country are not usually and efficiently applied. So we are still experiencing situations for which we already know the cause and the solution, but which are still not properly managed in the specific context of occurrence. I would like to give you some figures about other countries in Maghreb region. I start by Morocco, with his 37 million inhabitants. Despite this, Morocco could reduce maternal mortality rate from 317 to 121 from 1990 to 2050. It's a good progress. But despite this progress, inequities persist in access to emergency obstetric care between urban and rural areas and between different socioeconomic classes. And even when the woman manages to overcome the access barrier, she does not even benefit from proper healthcare quality. You all know that Algeria is the vastest country in Africa, so we can understand the problems of transport and transfer of severe cases. Although 95% of deliveries take place in inadequate setting, maternal mortality remains high in Algeria. So the reduction in maternal mortality from 216 to 114 during 35 years remains too slow. So we report here two large regional discrepancies. For example, maternal mortality rate in southern Algeria, in Tamarest, for example, is significantly higher than northern areas like Algiers or Blida or Oran. What about Mauritania, which is a very vast country too? Mauritania has unfortunately the highest rate of maternal mortality in Maghreb, with the number of 65 per 100,000 live births. And every day, 13 women die during pregnancy or childbirth. The main cause are multiparity, high incidence of preeclampsia, and the lack of family planning. In Libya, I think that we haven't the real situation because there is no register recording maternal deaths in Libya. As you can see, in 2015, there was only 9 deaths, maternal deaths. There are rather some biased statistics which don't reflect the reality in the field. So my main message that it is very important that the committees working on maternal mortality statistics should be independent of political bodies and provide credible figures which will be useful for implementing. It's very, very important. I will pass this slide. Which summarize the maternal mortality data concerning 3 Maghreb countries. This table shows a comparison in speed of reduction in maternal mortality rate in Morocco, Tunisia, and Algeria. It is clear that in Tunisia, the drop showed down during last 10 years from 4.4 to 1.8 because of social, political, and economic distance. So the causes, the preventability, and the associated determinants in maternal death. As we said before, women die during childbirth because of dysfunctions in the 3 levels. For the level 1, consult health service, the causes are the lack of information, low women's status, and social cultural perception. For the second delay, the causes are the lack of transport, the main causes are the lack of transport and the low resources. And for the third delay, the main causes are lack of drugs, equipment, and qualified staff, and poor distribution of qualified professionals. So, the postpartum hemorrhage is the leading cause of maternal death in Maghreb countries. It is the most dependent factor on perinatal care quality, and all authors attribute that to lack of care accessibility, lack of staff experience, inadequate equipment, inappropriate treatment, and often delayed transfer. Our medical response to PPH due to inertia is the early diagnosis of HPP is the key of success. Women screening risk for uterine atonia since early in pregnancy, and I advise to generalize the use of graduated blood collector after delivery. It's very important to do an early diagnostic of HPP in order to manage it well. Second, to respect protocol using uterotonic. And I advise to use intrauterine balloon tamponade. It's very, very efficient procedure in front of moderate and early HPP. It's important to follow the FIGO and WHO guidelines. It's important to train and supervise the residents to uterine myometrial compressions and vascular ligation techniques. Our responses to problems, our current challenge is to improve maternal health care are to creating an enabling environment for it, and to facilitate access to essential healthcare services, and to strengthening healthcare systems by providing women again and again with the necessary information. The inequities in Maghreb countries remain the core of the problem as for maternal mortality and health. These inequities are reflected in mortality and morbidity rates, but also in available human resources, socioeconomic, geographic, and cultural environment gaps. These inequalities are little or not recognized and have become the center of our social, political, and economic concerns. If one day the health strategies are achievable, concretely, we must discuss the quality of care, the location of healthcare facilities, the rehabilitation of the local public sector for the most vulnerable, and the regulation of the private sector and social insurance. There is, moreover, the obvious global framework of determinants such as education, sexual education programs in early schooling. I think that is very, very important. Transport infrastructure, access to public healthcare facilities, employment, and governance and accountability. It would also be necessary to place greater emphasis on quality insurance programs for care and to implement some projects such as the standardization and certification of maternity hospitals, the structuring of sponsorship between levels of care, and leading maternity hospitals in the accreditation of care structures and services. In this regard, the monitoring of maternal death will require the involvement and coordination between all structures related to the declaration of death, such as hospital structures, private sector, and community. FIGO organized a current initiative, IEC initiative, and the 2 steps are building blocks for equitable maternal, infant, and family centered timely, effective, and respectful care that can be implemented by facilities, centers, hospitals, and units that provide before, during, and after birth care to women and their babies around the world. It also discusses working conditions and relationship between healthcare providers. Tunisia was recently involved in this initiative in order to improve the conditions of childbirth status for Tunisian mother and newborn. So in my first conclusion, safe childbirth is based on 7 pillars of safe motherhood and childbirth. Efficient primary health care, family planning, prenatal services, qualified obstetrical care, postnatal care, post-abortion care, and reduced delay. Maghreb countries have made many efforts to reduce maternal mortality, but this mobilization will have to be better managed because of the persistence of regional and even local disparities, making this task even more difficult. To improve the efficiency of maternal mortality reduction strategies, it is not enough to develop medical interventions, but also necessary to promote consultation aimed at better covering the population by maternal health service. I think that general physicians, and especially midwives, have a great role in screening early diagnosis pathologic pregnancies and transferring them on time to specialized centers. So, the mandatory compulsory training is very, very important in this field. So Maghreb countries require better political commitment, allocation of resources, and improvement of accessibility to the continuum of the care. In the end of my presentation, I would like to remind you the important vote in FIGO. My brother, Dr. Faisal Al-Qaq, for the post of president of FIGO. So I would like to remind you and Dr. Philippe Descamps from France, Philippe Descamps, our colleague from France, who is running for the vice president post and who know very, very well our situation and is ready to invite them. Thank you very much for your attention.
Thank you, Dr. Khalid, for this excellent, comprehensive view of maternal mortality in the Maghreb region. And as we can already see, there is a variation between countries in the region. We have Saudi Arabia and the Gulf states with figures different from maybe our figures in Jordan and Lebanon. And I'm really surprised to find out about the figures in the Maghreb region. They're higher than what's reported in Jordan, Lebanon, and the Gulf states. But what's interesting that every country is doing its own policies to improve things regarding maternal mortality, and that's an excellent thing, I think. Is anybody from the panelists who would like to ask Dr. Khalid any questions, please?
Dr. Khalid, مساء الخير. Hello, how are you? May I ask you, one of the things that I have noticed in your slide, that people will accept that the woman's fate is to die, is accepted. Didn't it change in 2021 and 2020 to accept the fate, the woman that can die and nobody can ask why?
Doctora.
Yes.
Do you hear me?
Yes, we can hear you.
Yes.
I think that is not my message at all. In contrary, in Tunisia, people and families live is very, very hard and don't accept easy the maternal death. I never said that in my presentation. I said in general, in some countries, but in Tunisia, in contrary بالعكس يعني في تونس وفاة الأم مش مقبولة تماما.
I agree.
وفي عائلات يدخلوا في هستيريا كبيره وفي يعني côté medical legal situation is very very hard in Tunisia about maternal mortality. بالعكس يعني that is not, wasn't my message in the presentation.
Yeah, thank you for clearing up this one. Thank you very much.
Yes, you're welcome.
Any more questions from the panelists? Okay, Dr. Khalid, thank you very much. I'll pass on the microphone to Dr. Abir Annab to introduce the last two speakers. Dr. Abir, it's all yours.
Thank you, Maher. It's my pleasure to introduce our next speaker, Professor Abdelhamid Atiyeh. He is an emeritus professor of obstetrics and gynecology at Cairo University. He served at many positions at the Supreme Council of Egyptian Universities, Ministry of Health, the Egyptian Fellowship Boards, National Population Council, the Arab Board, and the Arab Federation of Evidence-Based Medicine. And he will talk about maternal mortality in Egypt. Please, Dr. Atiyeh, it gives me a great pleasure to see you again.
Thank you very much, Dr. Abir. I would like to thank Dr. Ahmed Abdelwahid, Dr. Maher Maaita, Dr. Mazen, Dr. Madani, and all of the Jordanian Society of Obstetrics and Gynecology for inviting me for this webinar to discuss maternal mortality in Egypt with my colleagues from different Arab countries. First of all, excuse my casual dress because I left the heat of Cairo and came here in the North Coast in New Alamein just to have some sea breeze. And this is the beautiful city of New Alamein. I hope to see you all here and enjoy the weather and enjoy the place. It's really, really a very marvelous place. It doesn't match the maternal mortality, but this is how it comes and how did it go. Anyhow, first of all, you all know that according to the 10th revision of the International Classification of Disease, the maternal mortality is a maternal death of a woman while pregnant or within 42 days of pregnancy termination for any cause related to or aggravated by pregnancy or its management, excluding accidental or incidental causes. The Millennium Development Goals set improving maternal health as one of the 8 Millennium Development Goals adopted by the International Committee, and the Millennium Development Goal 5 commits countries to reduce maternal mortality ratios by 75% between 1990 to 2015. However, between 1990 and 2015, the global maternal mortality ratio decreased only by 44% from 75%, and with 99% of maternal deaths occurring in developing countries. In spite of this, Egypt has a success story and has set an example to be followed. As you know, Egypt is a low middle income country. It's a very populous country with a population of around 102 million in mid-2021 and a population growth ranging between 1.9 to 2.2% per year. This makes more than 2.5 million pregnancies per year and more than 2 million live births per year. So actually we are having a lot of deliveries to deal with and a lot of mothers to take care of. Surveys to determine the magnitude of the problem and the causes of maternal deaths were the primary tools on which preventive strategies are to be based. In 1989, the maternal mortality ratio in Egypt has been estimated to be around 220 per 100,000 live births, a very high maternal mortality ratio actually in that year. In Egypt, the Ministry of Health and Population, supported by the USAID, carried out 2 national maternal mortality surveys. The first one was in 1992 and the second was in 2000. This is the 1992 maternal mortality survey that found that the maternal mortality ratio in 1992 was 174 per 100,000 live births. And it is very obvious that in Upper Egypt, the maternal mortality ratio is higher than in Lower Egypt. It was 217 per 100,000 live births in Upper Egypt and 132 in Lower Egypt. very young and very old mothers are risk factors for death in that survey. Also, the higher the parity was, the higher the risk of death during delivery. Hemorrhage represented 31.9% of maternal deaths in that year, and hypertension 15.9%, followed by sepsis as 8.4%. This when we speak about the direct causes of maternal death. But when we speak about the indirect causes, we find that cardiovascular disease was responsible for 12.8% of the deaths, because we have rheumatic heart disease in Egypt. So cardiovascular disease actually ranks the third in the causes of maternal mortality after hemorrhage and hypertension, followed by sepsis. The majority of cases of deaths, 92% of the maternal deaths in 1992 were maternal deaths due to avoidable factors. Substandard care was responsible for 71% of the maternal deaths, either from the obstetric team, from the general practitioners, or even from the dayas or traditional birth attendants that addressed 12% or had 12% of the maternal mortalities. Delay in seeking medical care from the women or the families themselves was responsible for 42% of the deaths. Lack of blood accounted for 6% of the deaths, and lack of drugs and supplies accounted for 2% of the deaths. The non-avoidable factors occurred only in 8% of maternal deaths. So almost all maternal deaths can be avoided, or the majority of them. Egypt has taken several steps to reduce the maternal mortality ratio. For healthcare workers, competency-based programs has been developed to upgrade skills of healthcare workers in 5 Upper Egypt governorates. Clinical protocols and service standards were developed and implemented. Specialists and senior obstetricians had to be present in hospitals 24 hours a day, and all surgical interventions are to be planned and done in their presence. Training manuals and curricula for traditional birth assistants were developed. Confidential inquiries have been established in many general and district hospitals of the Ministry of Health and Population. For the healthcare facilities in 1997, a program of blood transfusion have been established. It is called the Swiss project in Egypt, because it was done with the Swiss government. Thousands of hospitals and healthcare units have been rebuilt, renovated, equipped with supplies, and upgraded all over Egypt. For the women and the families and the community, a national mass media campaign through home visits and talks by trained health educators and non-governmental organizations, outreach workers has been established. Many interventions to address delay in seeking care have been developed and implemented, especially in Upper Egypt. Programs to increase modern contraceptive use and to decrease the total fertility rate were continued and fortified. This took us to the 2000 maternal mortality survey. In the 2000 maternal mortality survey, a great progress has been achieved. The maternal mortality ratio has dropped by 52% from 174 to 84 per 100,000 live births. And the maternal death was 10.3% of all female deaths in 1992. It became only 6.9% of all female deaths in the year 2000. And we can see here that the maternal mortality ratio has dropped 52%, the total maternal mortality ratio, but in Lower Egypt, the maternal mortality ratio has decreased only by 29%, while in Upper Egypt, the maternal mortality ratio has decreased almost by 60%. This is because all efforts were directed, or the majority of efforts were directed toward the Upper Egypt, where we had a very high maternal mortality ratio before. So the maternal mortality ratio in Upper Egypt dropped below that of Lower Egypt, 89, and here in 93, totaling 84 per 100,000 live births. And again, in the 2000 survey, old age is a higher risk for maternal death. The higher the parity also is the higher the risk of maternal death. And postpartum hemorrhage still the #1 killer for 34% of the cases, while antepartum hemorrhage was responsible for 9% of the cases, hypertensive disease responsible for 22% of the cases, and for the indirect causes of maternal death, still cardiovascular disease was responsible for 13%, and we had a program for anemia screening, and it was responsible for 11% of maternal deaths. This highlights the changes that happened in Egypt between the 1992 and the 2000 surveys. Deaths due to substandard care by healthcare providers have dropped from 71% to 66%. 66% is not a very big drop, but given that the absolute number of maternal mortality has dropped, the maternal mortality due to substandard care has dropped much, reflecting a gradual improvement of healthcare services. Delays in seeking medical care decreased from 42% to 30%, indicating enhanced community awareness. More pregnant women were assisted during birth by a skilled attendant. 61 were delivered by a skilled attendant versus 41 in 1992. There also was an increase in the number of healthcare units, primary health care, and hospital beds in Egypt. This reversal in maternal mortality ratio between Upper and Lower Egypt reflects that maternal health interventions were more extensive in Upper Egypt than in Lower Egypt. And also it's a very good indicator that success of the applied interventions, because there was marked drop in the maternal mortality ratio in Lower Egypt, in Upper Egypt. In spite of this, hemorrhage continued to be the major cause of maternal death, and lack of blood also contributed for 16% of maternal deaths, rising from 6% in the 1992 survey. So, although an Egyptian-Swiss project has restructured the Egyptian blood transfusion service, yet it has started only 2 years before the survey in the year 1992. Further steps were taken after the 2000 survey. The Ministry of Health and Population extended its previous successful programs to all over Egypt. In 2002, the Ministry of Health and Population has established a national maternal mortality surveillance system to allow for the identification of maternal deaths, determination of maternal mortality ratio at a national and governmental and governance level, and also the determination of causes and avoidable factors for maternal deaths, and most importantly, setting program priorities, developing improvement plans, and taking timely corrective actions where it is needed. So from 2000 to 2010, there was a national maternal mortality surveillance system. Through it, all maternal deaths are to be notified to the Maternal and Child Health Department and the National Health Information Center. This surveillance system made use of more than 5,000 health offices covering all over Egypt, the accurate system for registration of births and deaths that was present in Egypt, and the National Health Information Center that are present in all the governorates and health districts. We have more than 300 health districts in Egypt. And these are the programs that has been extended after the year 2000s. Many programs and many initiatives have been extended to implement guidelines, to train physicians, to train dayas and traditional birth attendants, and all the programs has been extended beyond the year 2000. According to the Ministry of Health data, this is the pattern of maternal mortality per 100,000 live births after the year 2000 survey. This is the first one in 1992. It was 174, dropped to 84 in 2000, dropped to 68, to 59, to 55, up to 54, or down to 54 in 2010. We can see here that in this 10 years, from 2000 to 2010, we have a 36% more reduction in the maternal mortality ratio in Egypt. Both in Upper Egypt and Lower Egypt, there was fair drop of the maternal mortality ratio, and the percentage of deliveries conducted by skilled personnel and at healthcare facilities rose to 79% and 73% of deliveries. So home deliveries are going to vanish. The direct cause of maternal death in 2010, still postpartum hemorrhage has a leading role, with almost a quarter of the deaths occurring due to postpartum hemorrhage, while antepartum hemorrhage only responsible for 2.7% of the deaths. Hypertensive disease is still the second common cause of death, followed by the cardiovascular, or sharing the place with the cardiovascular disease that we are having a problem with, the congenital, not congenital, the rheumatic heart disease in Egypt in young ladies and young girls. The time of maternal death is almost around 40% of maternal deaths in Egypt occur during delivery, and in the postpartum period, another 35% of deaths occur in the postpartum period. Only a quarter of the cases die during pregnancy itself. After 2010, between 2010 to 2015, there was a period of turmoil and political instability in the country that affected all development plans. However, the decline in maternal mortality ratio continued. In 2013, it dropped from the 54 of 2010 to 52.5. In 2015, it was 49, and this is considered 72% drop from 1992, and we don't know how much drop from 1990 because we didn't have the figure in 1990 to see how much did we succeeded in achieving the Development Millennium Goal 5. In 2016, it was 45.9, dropping in 2017 to 43.9, and in 2019 to 42.8. Actually, the projected and estimated numbers by the WHO, UNICEF, UNFPA, World Bank, and the United Nations are much less than what I am saying. But I didn't rely on the estimated or projected numbers. As you can see here in 2017, it should have been 37, but I used the maternal surveillance system of the Ministry of Health and Population to get the real numbers that has been achieved in our country. According to the number of the National Maternal Mortality Surveillance System, these are the numbers. When we compare the 220 of 1989 to that of 49 in 2015, we will find that this has decreased by 78%. When we compare the 1992 number with that achieved in 2015, we find that it has dropped by 72%. But what about the actual number that should have been in 1990? We don't know. So we are almost achieving the Millennium Development Goal of reduction of 75% from the 1990 ratio. And between 2010 and 2019, we had another 21% reduction in the maternal mortality ratio. We have challenges and future priorities. Despite the demonstrable success today, Egypt faces a number of constraints and ongoing challenges that, if it addressed, could help to ensure that its achievement of Millennium Development Goal 5A is sustained. These include reducing the socio-economic disparities, particularly between Upper and Lower Egypt, strengthening gender equality, improving the nutritional status of children, and we are having currently a project for improving the nutritional status of school children, and this project is supervised by the president himself, increasing financing for the health sector to reduce out-of-pocket expenditure. We are having 60% of health expenditure is out of pocket from the citizens themselves, and expand health insurance. We are having a system for total health insurance that has started in some of the governorates and will gradually cover all over Egypt, addressing health sector reform to reduce waste and fragmentation and improve the quality of services. Another challenge and the future priority: although the maternal mortality rate declined and the number of deaths due to postpartum hemorrhage declined, the current status and trend, which caused by avoidable factors like postpartum hemorrhage, may hinder the country from achieving the new 2030 Millennium Development Goal. We have the WHO and the international community has set another goal. In 2030, we should reach or every country should reach 2/3 the maternal mortality ratio of 2010. So the postpartum hemorrhage still persists and represent a burden that hinders us from achieving the 2030 goal. Research efforts to address the challenges and opportunities will help meet the postpartum hemorrhage prevention and the treatment needs. There are lessons learned. The first lesson learned is that a national maternal mortality study that provides an estimate of maternal mortality, information on the causes and avoidable factors contributing to maternal and infant deaths can be used as an important tool in the management of safe motherhood programs. Development, standardization, and dissemination of national clinical protocols are key to improving maternal and neonatal care. Staff skills and commodities, from emergency rooms to operating rooms to anesthesia to labs to central sterilization and to blood banks, have to be improved in obstetric and neonatal departments to reduce avoidable deaths and complications. Clinical training alone does not change provider attitudes and behaviors. Most providers adopt clinical protocols and master skills after on-the-job training with expert clinical supervisors. So you have to train the supervisors and the seniors first to train the junior staff. Safe motherhood committees, supported by ministerial decrees established at all levels, can help ensure sustainability of service. Investing in the development of a strong national maternal mortality surveillance system can yield timely maternal mortality data. And the Egyptian, finally, the conclusion, I'm sorry, my mouse is behaving badly. In conclusion, the Egyptian experience showed that the investment of sufficient resources to provide timely obstetric and neonatal care saves women's and newborn lives. Governments and international donors can draw on the Egyptian example to develop programs to meet the safe motherhood objectives of the Millennium Development Goals. A new Millennium Development Goal was set so as by 2030, the global maternal mortality ratio is to be reduced to less than 70 maternal deaths per 100,000 live births, and that countries have to reduce it by at least 2/3 from their 2010 baseline. And thank you very much.
Thank you very much, Dr. Atiyeh, for this an excellent presentation. And the floor is opened for the panelists and the attendee for questions.
Abir, can I come in?
Oh, yes, please. Go ahead, Muhammad. Maher, sorry.
Thank you very much, sir. Excellent presentation. Now, I have to congratulate you. It's what you've done was marvelous, and you've managed to reduce the maternal mortality I know it's still a long way to go, but you've achieved a lot in the last, say, 20 years or 30 years. That's excellent. My question is, would people in Egypt accept post-mortem exams on patients who die after delivery or during delivery, or is it a challenge for you?
No, it's a challenge, actually. People usually refuse post-mortem examination. They only accept post-mortem examination if a lawsuit was raised. So if they are going to notify the police and the judicial system about the death of one of their family, they will accept post-mortem. But the majority refuse, of course, post-mortem, and maybe, or perhaps this is one of the causes that they do not notify about the maternal death to avoid the post-mortem examination.
And do some of these cases go to courts?
Yes,
especially the unavoidable ones. The unavoidable ones.
Well, even some complications may go to court, not only maternal death. We are in Egypt now having a strong direction against the doctors and against physicians. And if anything or any mistake has happened and the people felt that they are not satisfied with what the physician has done, they go to court. Yeah.
Thank you.
You're welcome.
Dr. Atiyeh, do you think if we restrict the home deliveries, this will decrease the maternal mortality in Egypt?
Of course, it will decrease, but we cannot restrict the home deliveries. So we have a system for training the traditional birth assistants, a system of midwifery that is going on in the country so that they can help more in home deliveries. And we always train them on the early signs of complications so that they can transfer the patient very early before things get complicated. Of course, whenever we decrease home deliveries, the maternal mortality ratio drops. But to avoid totally home deliveries, I think that this needs a long time, not very soon.
And the other question, do you think if we restrict deliveries in our countries to 2 or 3, this will decrease also the maternal mortality? Although we might not have the power to do this, restrict number of deliveries. Let's say like in China, they do 1 or 2. Do you think this is applicable in our areas to do 2 or 3?
No.
Do you think this can decrease the maternal mortality?
We cannot restrict the number of deliveries, but what we are doing is that we try to get down the total fertility rate. When you bring the total fertility rate down, you have less deliveries, and will be reflected on less mortalities. So we are trying to bring down the total fertility rate. We are trying also to increase the contraceptive prevalence rate, especially on new contraceptives, so that we can minimize the unwanted pregnancies. In all of our surveys, unwanted pregnancies are about 10 to 12% due to unmet needs of contraception. So we work through improving contraception prevalence rate and reducing the total fertility rate, not by restricting the number of deliveries per woman.
There's a question from... Okay, go ahead, Maher.
Dr. Abdulhamid. Okay, just quick question. I mean, you've mentioned the high rate of cesarean section in Egypt, which I mean, I was in Egypt a few years ago and we had discussions about that. I mean, did you find there that some of those maternal deaths are associated with cesarean sections?
This is the question that has no answer. Why? Because I tried my best to get data from the Ministry of Health and Population. And all what I could get is that the total maternal mortality ratio. There is no publication that divides the causes of death like we have done in 2010 and in 2000. From 2010 till 2020, we didn't have any publication explaining the causes of death so that we can see whether the excess cesarean section rate has contributed to the maternal deaths or not. But generally speaking, the maternal deaths are coming down. This does not mean that cesarean sections are good, but at least it didn't lead to an increase in the total maternal mortality ratio in the recent years.
Okay, thank you.
Okay. Dr. Atiyah, there's a question from Dr. Muhammad Al-Madani, رئيس الجمعية عندنا. بسألك, what about maternal deaths in Egypt during COVID? Do you think it is increased by COVID infections in 2019 and 2020?
Yes, I had some sort of conversation with people who are responsible for the maternal mortality surveillance system while I was preparing myself for this meeting. And they told me that in the 2020 maternal mortality ratio, there are excess numbers due to the COVID. And I have a figure, but I don't want to declare it because it is not official yet, but we have excess mortalities in deliveries due to COVID-19 that happened in 2020.
Okay, thank you. And my last question will be, do you think women empowerment and investing in their education will improve the maternal mortality rate?
Definitely, because maternal mortality ratios is stratified by the socioeconomic standard and by even the level of education and the level of literacy.
Yes, I think we have one more question. Let me just check that. Okay, it's the same question, also asking about COVID-19 in Egypt. Did it increase the maternal mortality? And the answer was yes. We don't have a figure now, but it's definitely had increased. And the same, I think, here in Jordan. I think Maher will talk about it now. Thank you very much, Dr. Atiyah.
You're welcome. Thank you.
Thank you, thank you. And I think we're going to move to our last speaker, Dr. Maher Maaita. It gives me the pleasure to introduce him. Dr. Maher Maaita is a senior consultant obstetrician and gynecologist at the Royal Medical Services in Amman, Jordan. He's head of the department at the King Hussein Medical Center. He has a subspecialty in fetal-maternal medicine. He's a clinical associate professor at the Faculty of Medicine at Jordan University, and he is the chairman of the scientific committee for the Jordanian Society of Obstetricians and Gynecologists. He's a board examiner since 2016, and he is a member of the Committee for Medical Liability in Jordan since 2018, and he will address maternal mortality in Jordan. Go ahead, Maher.
Thank you, Abir. Can you see my slide?
Yes.
Thank you very much. I'm going to go through my presentations quickly. I know that you had a long evening, and some of the messages I have in my presentations already mentioned. So the definition is clear to all of you. Unfortunately, globally, around 80% of maternal deaths are due to obstetric complications, as in hemorrhage, sepsis, unsafe abortion, preeclampsia, eclampsia. Complications of unsafe abortions account for about 13% of maternal deaths. And the sad thing is almost 70% of cases of maternal mortality are preventable. And that's what we got from the previous presentations. If you look at some figures, you can see that Sub-Saharan Africa and South Asia, they unfortunately account for approximately 86% of all maternal deaths worldwide. On average, the good news, there is some decline in the maternal mortality rates across the board. And I'm sorry, I'm just trying to something. Yeah. Ibrahim, my slides are stuck.
Doctor?
Yeah.
I stopped your sharing and...
you want me to start to share again?
Yes.
Okay.
Okay.
Okay, I'm still stuck. So I'll stop sharing and then do it again. Can you see it now?
No. دكتور اطلع من البرنامج كله تاع السلايد بعدين ارجع ادخل مرة ثانية.
Okay, that's what I'm going to do. So I'm sharing now. Share.
Yes.
They're not moving.
لا هي اشتغلت دكتور.
Okay, I'm moving them in a different direction. Okay, the main factors that prevent women from receiving or seeking care during pregnancy: poverty, distance to facilities, lack of information, inadequate and poor quality services, culture, beliefs, and practices. If we look at the regions, you can see in Sub-Saharan Africa and Africa, they have the largest or the worst figures, if you like, when it comes to maternal mortalities. If we look at the MENA region, Pakistan and Morocco have the worst figures compared to the other countries. And as you can see, the Gulf states have good figures, and that's what we heard from Dr. Hassan's presentation. Now, moving quickly to Jordan. Jordan is a small country with a population of 10.6 million, 9,000 square kilometers, around 200,000 deliveries per year. Our cesarean section rate is about 25 to 50%. Now, neonatal maternal ratio is about 15 per 1,000. The health system consists of Ministry of Health, Royal Medical Services, army hospitals, private sectors, and universities. And as I said earlier, almost 95% of mothers delivered within the health institution, providing skilled care at birth. And recently, we have introduced the medical liability law. Reported figures in the past ranges from 41 per 100,000 to 63, but people believed it's in around the range of 50. And that's why it was important to establish the Jordan Mortality Service and Response System. This was back in December 2015, where His Majesty King Abdullah decreed the establishment of bylaw number 10 of the year 2016 of the Public Health Law, which mandates the notification of all deaths among women of reproductive age between 15 and 49. And this basically established, monitored the national maternal mortality surveillance and response system across all health sectors. This project, very similar to Egypt, was sponsored by USAID. So we have experience with when it comes to national or established surveillance. We have the National Cancer Registry in Jordan. We have collaboration between departments in the Ministry of Health, and at the time being, hospitals and only forensic medicine departments are the only entities entitled to issue a death notification form. So the system attributes aims to qualify or quantify the maternal mortality ratio for Jordan, active surveillance, assign a main cause of death, which is very important, and defines contributing factors to the death, and then establish a national system. The steps will include notification, identification, review, analysis, and then response and dissemination and monitoring. So it's an excellent system, and even we had committees and Dr. Mazen with us in the committees. So they have commitment. The host is the Minister of Health. The Public Health bylaw gives us the legal cover, and then we have to work and approve our policies and procedures, and we have different partners helping in the project. So the way we've managed this is we have organizational, structural, established roles and responsibilities defined, and then a system established and functioning at all levels. And you can see from the slides that there are different steps. Monitoring as well of the system was an important part. Then we had to look at the technical competence built for all levels of implementation. We have to train national advisory groups. We have to look at the directorate and we have to Ministry of Health as well. So all these things are very important. And then we have to train people, train the trainers. We have to have infrastructure. We have tools and forms developed. And then we have guidelines for implementing and developing the system. And I'm very proud to give you two reports, one covering 2018 and one covering 2019. And I'm just going to quickly go through the results. So the results in this presentation cover the period between January 1st to December 31st, 2018. And in this period, we had, unfortunately, 1,247 deaths reported among women of reproductive age. Okay, I'm having more problems. A total of 62 deaths were identified as maternal in this period, and we had a total of 917 live births, and then that gives us a maternal mortality rate of 29.8 per 100,000. So we were very pleased. I know the figures, every maternal death is a sad story, but at least we have a base to go for, and then look at distribution of maternal mortality. Again, the age is an important factor in the figures. By nationality, most of the deaths were Jordanians, but because we had Syrian refugees, and you can see 10% of the deaths were Syrians. We had Palestinians, and we had a Pakistani lady. By educational level, you would expect, as we listened from the previous presentations, that most of them, 42 had secondary education, 29.8 had higher than secondary, 22 basic, and 5.3 illiterate. Most of the ladies in Jordan, they have high school, at least a high school level education. Unemployment, almost 90% of them were unemployed. Deaths by parity, as would you expect, most of them were multiparas. Timing of death, as we heard from previous presentations, most of them, unfortunately, in the period, we had deaths during pregnancy and post-miscarriages. The majority of deaths in the postpartum after delivery took place within the first 24 hours. Care visits, again, this is an important thing because most of our ladies had 4 visits or above. And then we had to look at the quality of the antenatal visits that we had. Maternal deaths by mode of delivery, and that's interesting, and this is why I asked Dr. Atiya about this, that we found that 62% delivered by cesarean section. So cesarean section in Jordan, unfortunately, might be a risk factor for maternal mortality. Now, we have to look at this in future reports, but you can see that 62.9 deaths is delivered by cesarean section. That's a very high figure. Causes of death, very similar to the previous presentations. We had obstetric hemorrhage, we had pulmonary embolism, we had amniotic fluid embolism, we had preeclampsia sepsis, and indirect. And as you can see, the direct cause is about 62.5, while 37.5 indirect, and the indirect is cardiovascular disease is the main one. So again, similar to neighboring countries when it comes to the causes of death. Now, deaths by level of delivery, again, very consistent with what we heard from previous presentations. We had delay in receiving care, we had delay in seeking care, and delay in reaching for the care, and no delay in about 30%. And that gives you an indication that maybe it's around 70% of these deaths are avoidable. And if we work on those, we will reduce the maternal mortality rate even further. Now, looking at the following report in 2019, and remember, this is before the COVID problems. So no COVID maternal deaths were reported in 2018-19, but unfortunately, we had few cases in 2020 and 2021. Now, maternal mortality ratio in this period, again, we had during this period, unfortunately, 1,451 deaths among women of reproductive ages. Total of 63 deaths were identified. Total number of deliveries less than the year before, 194,000. So we had the higher figure of maternal ratio of 32. So in Jordan, I can confidently say that our maternal mortality rate is around the figure of 30 per 100,000. That's based on 2 consecutive years. I know we still have a long way to go, and we have to look at figures for the next 5 years or so. But again, that's the most accurate figures that we had, and these figures are recognized by the WHO. Now, again, looking at the data quickly, multiparas, much more in this group. By age group, slightly different. We don't have the old ages. We have most of them between the age of 25 to 29. This is the average age of marriage in Jordan. Again, almost 2/3 were postpartum deaths, so that's a very tricky thing, and postpartum is a very risky period for delivering in Jordan. The majority of deaths in the postpartum period place between 1 and 7 days as well. Again, most of them had a few antenatal visits, and that's important because we have to look at those, what kind of quality of antenatal visits we're having if we want to reduce the maternal mortality rate. Mode of delivery, again, we had the same problem. 47.6 of deaths delivered by cesarean section. So is it the surgeon? Is it the anesthesia? Is it the place that they underwent cesarean sections? And again, that's consistent of what we've been hearing, that In Egypt, they improved things because they improved the quality of the surgeons and the doctors and the high level of cover, 24 hours and so on. That's one of the things that we're working on in Jordan to reduce the cesarean section rate, because we believe if we do that, then we can improve our figures. The causes similar: thromboembolism, hemorrhage, hypertensive disorders, pregnancy related, with cardiovascular as indirect causes. Again, you can see we still have delays in seeking care, delays in reaching for care, delay in receiving care, and delay in seeking care. And again, 80% of those deaths, unfortunately, you can label them as avoidable. And that's where we have to improve on this area. Challenges, yes. What we found is poor documentations in medical files in most of those cases. And unfortunately, again, we did have a look at like smoking, high BMIs, anemia, things like that, which might be contributing factors to maternal mortality. And that's something we need to look in the future reports. Infrastructure of the health system in some areas away from the capital or the big cities, we have problems, and we have to look at these problems. Substandard care in some regions and hospitals, again, which is consistent of what we've been hearing tonight. We need to implement guidelines and protocols in all these maternity units, and we have to look at multivariant analysis. As I said, some of these analyses are missing, and we cannot judge from the numbers that we have, really. And we have to look at near misses as well, with implications and the effect on maternal mortality. I think the figures are still small to analyze them in a big way. And we have to look at the avoidable factors and identify them. We have to look at evidence-based medicine approaches in dealing with the management of cases. And we have to prioritize actions based on feasibility, resources, and system readiness across the country. And we have to establish a timetable and look at short, immediate, and medium and long-term improvement in our response. So we started on the response by integrating recommendations within plans and health system packages. We decided how to monitor progress, effectiveness, and impact. We monitor to ensure recommendations are implemented, and we look at implementing those plans as well and see if they will affect our future figures. We have to look nationally, we have to look at the facilities, we have to look at the communities, and we have to look at the level of the response, and we have to look at short-term and long-term implications. Some of these responses quickly, we have adopted strategies for the prevention management of the most common causes of maternal deaths, and we have to look at preeclampsia guidelines, pathways for thromboembolism and preeclampsia. Again, with the help of USAID, we have to look at antenatal care, and the health providers develop clinical guidelines and pathways for the provision of antenatal care services. And we have to look at cesarean sections, because our findings are consistent with the fact that we're having problems with our cesarean sections. Develop the national guidelines to support vaginal birth and reduce primary cesarean section deliveries. However, our cesarean section rate is not too bad. I mean, compared to Egypt, we're much lower. Even between different health providers, maybe it's the highest in the private sector, but in the national health system, it's still in the range of 25 to 30%, which is not bad. We have to look at those guidelines, and then we have to, as was mentioned in the previous presentations, the uptake of quality and effective family planning as well, because that will reduce the maternal mortality. The evidence is there. So the national access to family planning services to eliminate the need for contraception, strengthening the capacities of healthcare providers on providing family planning counseling, postpartum counseling. So linking response to action is very important. And I think I'm still, okay. So maternal mortality reduction requires concerted efforts from all levels of healthcare systems or system providers, from the community up to the central headquarters of all health stakeholders. Maternal mortality reduction is measured by trends over years, not 2 successive years, and this from Dr. Atiyah from Egypt. So we have to look and may require up to 10 years to elicit significant changes. I believe a baseline to work on. We are convinced that maybe a 30 is an adequate number. Hopefully we will be working on it to reduce the number even further in the next 5 or 10 years. I think Jordan is committed to the SDG 3 of the United Nations. It's a great achievement, and we are very proud of that. And we believe because we are the second country in the region after Egypt to implementing a maternal mortality surveillance and response, which is published on a yearly basis or every 2 to 3 years. I think we have commitment in Jordan for all health providers because that's very important. And we are working on the response. What happened in the last 2 years because of the COVID, it delayed our response, but we're working on it, and we have protocols and guidelines to implement. And as I said earlier, unfortunately, we lost few ladies with COVID and pregnancy in the year 2020 and in the year 2021. I think our target, as was mentioned, may be to improve or to reduce the maternal mortality rate by 20 to 30% over the next 10 years. I believe, and as you all believe, no woman should die whilst bringing life into this birth and into this world. And I thank you very much for listening, and I'm happy to answer any questions related to our experience in maternal mortality in Jordan. Thank you.
Thank you, Maher, for this excellent presentation. Dr. Atiyah is raising his hand. Go ahead, Dr. Atiyah. Please unmute yourself.
Thank you, Dr. Maher, for this very excellent presentation. I have a question about the cesarean section mortalities. Do you have analyzed the mortalities during cesarean section, whether it is due to anesthesia, pulmonary embolism, due to adherent placenta, postpartum hemorrhage? What are the causes of mortality during cesarean section? Do you have an analysis for it?
We don't have a full analysis because of poor documentations. But some of those patients, they were labeled cesarean section, but we went in, they had accretas. Some of them were done in remote areas. We're not sure of the competence of the surgeons. Some of them had bleeding. Some of them had anesthesia related. So these are the causes. But I think in the future reports, we have to look and analyze them in more details. But I think most of them will come under the title hemorrhage, unfortunately, which is consistent with what we've been talking about all night. So hemorrhage is still a main cause of maternal mortality in our region, unfortunately.
Okay, thank you.
There's a question from Jacqueline Kosha. And do you think general anesthesia or epidural or spinal had more incidence for maternal mortality in your study?
Well, I mean, I don't know about all the sectors, but we know for a fact that spinal anesthesia is much safer, and only very few should be done under general anesthesia. You have to exclude the accretas and the bad accretas because that's a different story. But I think spinal is much safer, and that's what's been done all over the world. So if we're talking about cesarean sections, definitely spinal is safer. There are only few indications for general anesthesia. Now, is it related? This is like Dr. Abdul Hamid was mentioning, we need to look at the data in more details.
Dr. Mazen Zibde, do you have a question or a comment,
yes,
please?
I have a question and comment. Thank you, Dr. Maher. Thanks, Dr. Atiyah, and all our distinguished speakers for very beautiful lectures for very important subject. I think as a partner in the study of the maternal mortality in Jordan, the problem, Dr. Maher, he mentioned that most hospitals, they do not follow protocols and guidelines. I think one of the most important things is going on now in Jordan after the creation of the responsibility and legality and المسؤولية الطبية is to ask about complications and to question the morbidity and mortality. And most hospitals and the team has laid down certain guidelines to control events and events going on in labor and in antenatal. And I think Dr. Maher mentioned lack of the protocols and guidelines is a major factor in the incidence of maternal morbidity and mortality. Because in Jordan, we have doctors qualified from different parts of the world, and everyone may practice in different way. We need to have is straightforward guidelines to direct all these clinicians in the same way, because without this, we cannot put a straightforward guidelines and then to implement it in different hospitals. We are lucky in Jordan that guidelines are written now and nearly implemented in most of hospitals. Dr. Maher mentioned that cesarean section, and Dr. Atiyah, thank you for asking this. Cesarean section is, I can't tell what is the cause of death in cesarean section, but in Jordan, 62% of the maternal mortalities, which Maher mentioned, they delivered by cesarean section. The reason for that cesarean section, whether it was elective primary cesarean or repeated cesarean or associated with maternal complications. So, but if we reduce the number of cesarean sections, the primary one, which we are working on it now, and we have guidelines now to reduce the primary cesarean section, then we will have less incidence in repeat cesarean section, less incidence in morbid placental complications, as well. Maybe we're talking about injuries and trauma and rupture uterus in the future. So putting guidelines, which is already Maher has put the guideline on one of his slides, we can reduce primary cesarean by putting guidelines for induction of labor and improving the skills in the antenatal and intrapartum care. If we do this and we implement it in all hospitals, I am sure this will improve the standard of care, and it will reduce the number of cesarean sections and will improve the maternal mortality in the future. And thank you very much. I don't have any more questions.
Dr. Hassan, تفضل.
Dr. Hassan, yes, go ahead.
First, I would like to thank the Jordanian Society for OBGYN and Dr. Maher, Dr. Ahmed Abdul-Wahid, Dr. Awir, and Dr. Mazen. Thank you very much for the excellent night. And the problem, I think, that we know that more than 70% of the causes of postpartum is preventable. We know that for the last 20 years or more even. Protocol Act is there. The protocol is there. Guideline is there. Our problem that until today, that these not implemented. Simply because I've seen myself when I am investigating the maternal death in different sector of hospital. يعني حاجات is very basic, how to be missed. How would you take a patient for an elective cesarean section for placenta previa and there is no cross-match for blood for her? That's just an example. Sometimes patient having antepartum hemorrhage due to placental abruption, and then she delivered, went to the postpartum hemorrhage. There is no proper care from the inexperienced people in the delivery room to monitor her condition before she collapse and die. So I don't think it's our problem is the protocol guideline and no implementation and supervision, and somebody should be in the labor room, the supervisor in the labor room, not every time change it from one person to another. And I've seen it even in the UK. I've been trained in the UK, and there is one person, one consultant looking after the labor room from A to Z. So they can follow up all the cases. Antenatal care is very crucial because I am going to separate the low risk and high risk. High risk, they need special care from my side. And I can pull that up and I put marker on that one. She needs special care. I cannot follow her up as the adjunct because that's what we can see. Ladies dying in front of us, and they said more than 70% preventable. Look at that causes, and I think very simply you can prevent it. Because all of us were talking about the guideline, a protocol, but it's there, but they put it against the drawer. That's just my comment. on tonight.
Abir, can I come in, Abir?
Yeah, please go ahead, Maher.
I agree completely with Dr. Hassan. The protocols have been there. People look at NICE, people look at RCOG, people have guidelines from all over the world. The problem is they don't implement them. Now, the thing that came across this evening is the variation as well in the maternal mortality in our region. I mean, if you look at the figures, they are, I mean, I was surprised about the Maghreb region. They have high figures. And look at Yemen. I'm sure Syria might be the same. Iraq. I mean, we have scary figures when it comes to maternal mortality. I mean, Egypt is a success story. Hopefully we'll follow what Egypt has been doing. I think the Gulf states are okay. They're all set because they have a very good health system and they have very good infrastructure. And the maternal mortality is always low. But we have problems in our region. We have problems in the Maghreb al-Arabi. I mean, I was really surprised to hear the figures in Tunisia and Morocco and Algeria. I mean, they're very scary figures. And I mean, that's very, very surprising. I mean, Yemen is not surprising, Dr. Hassan, because they are at war and
yes,
they always have problems. But their figures, unfortunately, are approaching the figures of Afghanistan, for example, and Pakistan. So,
yes.
I mean, that's something that maybe Al-Jama Al-Arabiya should work on. Maybe, I don't know, maybe, Dr. Atiyah, what your views on that? How can we work and improve maternal mortality in the Arab region? Because what came across from this webinar, sadly, that a lot of ladies are dying unnecessarily. So I would like to hear your views, Dr. Atiyah.
Well, it's a very difficult situation actually with all of the turmoil going on in Yemen, in Syria, in Libya, and in those countries. It's very difficult to help, at least in this time. But I wonder, we have Dr. Hassan Jamal and the Obstetrics and the Federation of Obstetrics and Gynecology. Perhaps through the Arab Federation, we can have a committee. This committee can contact the Obstetrics and Gynecology federations or the ministries of health and population, and we can offer our experience to them, and so that we can help in this. I don't have a definite plan right now, but perhaps we can work on something like that in the future together.
Dr. Mazen?
Okay, thanks. Dr. Jamal mentioned that guidelines are written and it is there with the NICE, the Green Top guidelines, American FIGO guidelines, all of these. But the problem is the implementation. How can you, in a large country like Saudi Arabia, where there's thousands of hospitals and maternity units, to follow the same guidelines and to train the midwives and the resident staff to follow these guidelines? Because if they don't follow these guidelines, or everyone, I know in Saudi Arabia, I worked in the university in King Faisal, we were highly trained staff, but I'm sure there are some peripheral hospitals where staff not too high class, like in Jordan as well, in Egypt, in Morocco, anywhere in the world. How you can enforce the staff, whether nursing staff, residents, and consultants, to implement the guidelines? Is there a responsibility law to question these people, not when mortality occurs, but when there is morbidity as well? Because women may not die, although guidelines are not implemented, but maybe is not receiving the high standard of care. So how you implement the guidelines in Saudi Arabia?
Right. Thank you. Implementation بيكون through assigning one of the consultant to the labor room. Not every day there is a consultant. There'll be one, like in the UK, when I worked there was Dr. Lieberman for the labor room for 3 months. He is looking after the labor room. That means he comes to do the round in the morning. He review all the cases himself. He look for the management of these cases, and 5 o'clock before he leave the hospital, he do another round and he say that room 1, room 2, he put the management. And with him, there is a senior registrar. So that means, in other words, you have to assign a team for the labor room, as you can see, that most of us, we can see the problem started from the labor room, and then it will follow. But that means if every day there is a consultant, will he just do round in the morning and that's it? Or maybe he will see only his patient, but he doesn't look to the policy and the guideline and act. But if I work, for example, in the King Abdulaziz University, I work for 3 months for the labor room. Nobody else I look after. After 5, the on-call consultant. But during the daytime, as I have been trained in the UK, I do it here. The other hospital, they try their best, but I agree with you 100% that not all hospital, not all sector you could follow. But that's the minimum you could do, at least to make sure that they can follow the guideline. Some of them, they have the guideline, okay? They got protocol. ما تقدروا في الدرج ما حد بيناقشها ولا الحالة دي بتطبق البروتوكول and so on. And that's my comment on that one.
Okay, excellent.
Yeah.
I think excellent.
This could be one of the problems, but there are other issues also to be discussed and more guidelines to be followed, and medical liability has to be there, morbidity has to be addressed. It's really, it's a multidisciplinary work, and it needs a teamwork, and it needs the supervision of the Ministry of Health and all the university hospitals and the military hospital and the private sector hospitals has to be hand in hand in trying to establish the proper management for these maternal mortality cases. And studying them really will just put your hands on the problems and try to solve each problem by itself, so you can reach to a less maternal mortality and a better quality of life for the mother and for the newborn.
But Abir, if you look at all the presentations, you will find 70 to 80% of maternal deaths in the Arab world are avoidable. That's the sad fact.
Yes,
and that's
definitely.
where if there is a huge room for improvement, and if everybody does his job, the seniors, the juniors, the middle grade, the midwives, the nurses, the politicians, the infrastructure of the hospitals, you will save lives. As simple as that. It doesn't need, I don't know, miracles to do it. But we have problems, and we have to look at these problems, improve these problems, and then automatically you will improve the maternal mortality rate in all these countries.
Yes, I agree.
يعني أنا
دكتور حسن تفضل، وبعدين دكتور عبد الحميد. تفضل دكتور حسن.
يعني أنا دائما حتى لما أنا بعمل تيتشنج للريزيدنت وكده بقول لهم الليبر روم this is an ICU for obstetrician. لازم somebody to look after. ما احنا زي اي وورد ثانيه وكده. اقول لهم بليز يس بس انا ICU for us. سو الشغل حقنا لما يكون فعلا تيم متكامل من الالف، يعني اجي بالصباح اعمل راوند وبعدين ارجع منتصف النهار وبعدين الساعه 5 قبل ما امشي بعمل المرور حقي لغايه ما اتاكد انه اول ويل. لو في هاي ريسك بيشنت وخايفين عليها ببلغ الانكول تيم وبكلم الكونسلتنت يكون هو عارف بالضبط انه المريض دي انتبهوا لها في روم 5. ترى روم 5 ما هي زي 1 و2 و3 نورمال ديليفري.
دكتور عبد الحميد تفضل.
هو الحقيقه احنا يعني في ستادي كنا عاملينها مع الجامعه الامريكيه في بيروت. لو كان الدكتور فيصل موجود كان موجود معانا في هذه الستادي. كانت الستادي ان مجموعه من الكونسلتنتس بيبقوا اسايند لكل مستشفى او لمستشفى معينه، بيناقشوا مع الستاف هناك كل حاله نير مس قبل ما تموت او نير مس، بيناقشوها وبيشوفوا ايه المشاكل اللي حصلت في هذه الحاله، وبيحاولوا ان هم يريكتيفاي السيستم اللي موجود في المستشفى. الستادي دي الحقيقه يعني احنا عملنا في مصر هنا، كنا مسؤولين عن مستشفى الجلاء للولاده، وهي احد اكبر مستشفيات الولاده في مصر يعني، واعداد الولاده. I'm sorry, I'm speaking in Arabic. The Jalaa Hospital has a large number of deliveries every day, not every year or month. And actually, the result of this study, there was a lot of improvement after this 1 year of continuous meetings with the staff discussing every near-miss case. And there was improvement. I think if there were some sort of consultants who are assigned this role to discuss all the cases, either of the maternal mortalities or near-miss cases with the staff in this hospital, and give recommendations to improve the service in this hospital, this may push things ahead a little and force them to implement the guidelines, perhaps.
Yeah.
May I add one final thing, Abir? Now, in the UK, as Dr. Hassan was saying, 20, 30 years ago, when we were junior doctors, we had a registrar covering the labor ward. Now, it's all consultants, even after hours, even after 5 o'clock until the morning. You have, now they employ consultants to cover labor ward 24 hours, 5 days a week, all the time. You have a consultant cover. And they've done it because the evidence is there. If you have a consultant on the labor ward, the maternal mortality will go down, the near misses will go down, the morbidity will go down. As simple. It's very simple.
Yeah.
Thank you.
Thank you very much. At the end, I think we thank everybody for this very fruitful event. And I want to remind you of our next webinar. It will be on the 27th of August at 7 p.m. local time. It will be about endometriosis. Dr. Mazen Zibdi and Dr. Abdullah Al-Fayyad are putting the last touches on the webinar. So we're looking forward to see you there and meet you again and discuss more things. So I thank you very much. Maher, do you have anything to add, please?
No, I would like to thank my colleagues for their excellent contribution, and I hope to see them in Jordan in person soon after this COVID nightmare.
Inshallah.
Dr. Mazen, do you have?
Okay. Thanks very much for all our speakers. And I think, as Maher mentioned, we're looking forward to see them and meet them in Jordan in person. And just to remind all our attendees that the next webinar will be on endometriosis. And we tried hard, the committee, whether the RCOG committee and the Jordanian Society, to make these activities in different themes. So obstetrics and gynecology, oncology, fertility. So we have been talking on obstetrics for the last 4 weeks. So the next 2 webinars will be endometriosis, and the one after it will be on infertility. Thanks again for all members who participated in this activity, and to my colleagues, Abir, Dr. Maher, and Dr. Ahmed Abdul Wahed, and thanks for the speakers as well. Good night, and hope to see you again.
Thank you very much, and good night, everybody. Good night.
Thank you very much. Thank you very much. Assalamu alaikum.
Thank you, Abir.